So with that, good morning. My name is Laura Carroll. I am the president of your Colorado Medical Services Board, and I am bringing this February 2026 Medical Services Board meeting to order. Mr. Sykes, would you please help me with roll call?
This is Chris Sykes, absolutely. Laura Carroll.
Present.
J.K. Costello. Present. Morgan Honey.
Present.
Amanda Jaslinski.
Present.
William Kennard.
Present.
Barry Martin.
I see him.
Kasana Littler.
Present.
James McLaughlin.
Here.
Christina Mulkey. Might be in the wings. And David Pump.
Good morning.
Madam President, we have a quorum.
Splendid. Thank you very much. And with that, I will carry on with public announcements. The date and location of the next Medical Services Board meeting is scheduled to be held Friday, March 13th, 2026, beginning at 9 a.m. virtually and in person at 303 East 17th Avenue, Suite 1100, Denver, Colorado, 80203. If you are listening via the audio stream and lose the connection, please click again on the link to rejoin the meeting. Closed captioning is available on your Zoom toolbar, and staff will chat out instructions. Please identify yourself when speaking comments, as they are part of the public record. It is the responsibility of the Medical Services Board to adopt the rules that govern the department's programs through consideration of stakeholder input, in alignment with the department's mission and in the best interest of all Coloradans. There is testimony sign up for the open forum and for each rule. If you need help finding the rule in which you are interested, please ask staff for help. Please keep your testimony related to the rule being discussed. After public testimony for a rule or public comment begins, we cannot accept any additional sign-ups for testimony. We will provide multiple opportunities to sign up before the deadline. Public comment today will be limited to 2 minutes. At the end of 2 minutes, your time will be up and we will move on to the next individual signed up to testify. Thank you. All right, team, and with that, I am next in line is a department update. Rachel, are you taking that this morning?
Good morning, Madam President. Rachel Entrekin here for the department. With me are Adela Flores-Brennan, our Medicaid director, and Bonnie Silva, the director of the Office for Community Living. So the three of us will be presenting this morning.
Looking forward to it. Thank you, team.
Thank you.
Okay, all right. I will kick us off then. Hi, everyone. Adela Flores-Brennan, Medicaid director for the department. Hopefully you can hear okay in the room and on the phone. So after last month's meeting, we realized that we needed to help provide a better foundation and context for all the things that we are considering both here at MSB and then also through other mechanisms like the governor's executive orders and through the legislative context. So we are going to back up a little bit and do some level setting and give some context on where we are with the state fiscal issues and what we have done over the past couple of years to identify places that we may need to pull back. I will start that everything off with the North Star that we are trying to adhere to is to not lose coverage. When we think about Medicaid generally, we don't have very many levers for cutting. So when we are faced with a fiscal crisis or a need to reduce our costs, we are generally limited to a reduction in eligibility, so cutting people, a reduction in benefits, so reducing whole benefits or parts of benefits, and then reductions in how much we're paying providers. Those are kind of the three. There's a fourth one out there. We think about trying to find value in our programs. And so that is another place that we are identifying. So are there cost overruns, et cetera, that we can be more mindful of adjusting for. So if I can get the next slide, I'll go into just the background on the fiscal context. So some things that are important to know is are that Medicaid is more than 1/3 of the state's overall budget. Our revenue growth generally is limited by the Taxpayer Bill of Rights, or TABOR, and other fiscal constraints. And like most other states, we have a balanced budget requirement in the state constitution. There have been, as you are well aware, federal policy changes, including HR 1, that had an almost immediate impact on the state's budget and hit us at about $800 million. That is because of how our taxable income is tied to the federal taxable income. So it automatically reduced the amount of revenue we had, which is why we went into a special session back in August. You'll recall that prior to then, we were already dealing with some revenue shortfalls that had to do with a reduction in ARPA spending that came to us through the public health emergency and other factors that just said that we, as a state, were not able to keep up with the level of spending that we were projecting over time as compared to the revenue that we were bringing in. So this is a multi-year, we are in the process of a multi-year need to reduce the budget. So what we have been confronted with is $800 million this fiscal year and additional reductions for the next fiscal year that are required in the amount of about $314 million for healthcare policy and financing. So a lot of pressure is being put on our department because of the amount proportionately that we consume of the overall state budget. If I can get the next slide. This slide just shows our total expenditures over time. So we have increased our spending by nearly 60% since 2018, state fiscal year 2018. And that's quite a lot. So you can see also in this represented our federal state partnership. So we have the dark blue showing how much of that is federal funds and the light blue as the Colorado general funds. Some of the things that, if I can get the next slide, that have helped to spur the increase over time is that we've actually had a lot of expansion in Medicaid. Here we've had an effort on this slide to highlight some of the expansions to eligibility, behavioral health, reductions in barriers to care. So all of these things have come about in the fairly recent past, last 5 years or so, 50 bills or more that have expanded eligibility, broadened coverage, and reduced barriers. So you can see here things like our Cover All Coloradans program. We've extended postpartum coverage to 12 months for our populations. The statewide behavioral health system and behavioral health administration, expanded crisis services, peer supports, mobile crisis, substance use disorder treatment, a lot of really important things on this list. And it has also contributed to our very significant growth. If I can get the next slide, this one is a little complicated, I think, to understand. As you may be aware, we had also engaged Manat Health services to help us with our sustainability. This was an effort to have a third party kind of come in and look at where are we seeing cost increases, where might we consider reductions or policy changes that help create some greater sustainability over time. So this slide is actually credited to them. We did do a little organizing with it, but the data and analysis is theirs. So what this is showing is where are our cost centers in Medicaid? So where are we spending the greatest amount of money in the Medicaid program versus what are the growth drivers? So what are the areas of Medicaid that are contributing to the highest amounts of growth over time? So we have long-term services and supports as the at the top of that list as both the highest cost center and also the biggest cost driver. We have the other category, and that just includes lots of things like administration, capitation payments, imaging, dental, hospital supplemental payments are next, behavioral health, then physician services, hospital inpatient, pharmacy, hospital outpatient, and then you get into some of our bigger benefits, NEMT, the non-emergency medical transportation, and pediatric behavioral therapy, showing about each at about 2% of total spending, but 4% of total growth. So our sustainability framework that we have been trying to use as a set of principles to help guide us as we move forward are addressing our drivers of trend. So you have seen what we have seen internally, and may not be as visible to our external stakeholders, is that we have been doing a lot of analysis over the last couple of years of our data. We have been really looking at where are we seeing these drivers of our growth trend.
Hey, Adela, we need to go to the next slide.
Oh, I'm sorry.
That's okay.
Next slide. I forgot the next slide, please.
It's not math.
There we go. Medicaid sustainability framework is the slide we're supposed to be on. And I will just pick up by saying we've been doing a lot of work to analyze what are the drivers of our trend, what is making our payments go up year over year. And as we look at those drivers, we're really trying to dig into, is this population based? Have we seen a growth in enrollment in a particular population? Have we seen any growth in the use of a particular code? Is there some fraud or waste or abuse in a particular area that we should interrogate? Those types of things. And so we've done a lot of analysis over time to really look at where we are seeing those trends. And the slide that I showed just before this shows where we're seeing those drivers. We are looking at how we can maximize federal funding. So if you remember back to the bar chart where we had the dark blue in federal money coming in versus the light blue in state money, are there ways that we can draw down more? A lot of our population is 50-50, 50% federal funds, 50% state funds, but we do have opportunities to draw in enhanced matches for technology changes. For our CHIP population is 65% federal funding. And then there are financing mechanisms that we can use through different waivers that can help bring in more federal funding. So have we explored all of those potential opportunities? We are looking for ways that in other places in the state budget, we can continue to invest in Coloradans so that we are not basically cutting off our nose to spite our face, recognizing that people who are Medicaid members have other needs in education and housing and food, et cetera. We are trying to, as we move forward, make reasonable cuts or adjustments. So we are identifying where we have programs and benefits and reimbursements that are comparative outliers. And so that is a lot of what you will see is us bringing forward places where we have identified outliers. We are also reassessing new policies. So even things that you have passed in the as a board in the past, we have paused some of those implementations. The big one that you may remember is the community health workers. We've had to pause those because it hadn't gotten into place yet. So we put the pause on that so that we are not incurring expenses moving forward. And then we are really being cautious about anything new that we are putting forward. Next slide. So here is something I think that we hear in the narrative sometimes, or we get asked a lot. It often does seem like we might be targeting a particular area or a particular thing for cuts. In these boxes, we are showing just some of the things that we have done to help reduce the budget, to help create a more general understanding that we are not just looking in one place in the budget or one population or one particular benefit. So you'll see in the yellow box that we have utilization that we are trying to control for. So in the case of definitive drug testing, for example, we saw some overruns there. We are reinstating, or we're looking to reinstate prior authorization for some outpatient psychotherapy. We, as I said earlier, are delaying implementation of community health workers. With rates, we had a 1.6% rate increase that we had to roll back. So that is across the board rate decrease. We are then reducing rates by another 0.75. We have an overall resetting of benchmarks to 85% of Medicare for a great number of our codes. What else? We're delaying, unfortunately, access stabilization payments, and those are impacting some of our rural small providers and pediatricians. On eligibility and enrollment, we've had to end continuous coverage. Now that one, we didn't make that decision. The feds made that decision for us, but nevertheless, that is, we are keeping it on here because it does result in a reduction in the budget. We are making reductions to immigrant family planning and a few other things like long-term services and supports, presumptive eligibility. It's a delay, again, because of federal decision-making or lack thereof. I will say that not all of these things come to the Medical Services Board. Some of these are in rules and we need to make changes. Some are not. Some need federal authorization, some do not. Some require us to have legislation in place or changes to statute, and some do not. So there's a lot happening out there that you all may not ever see at the Medical Services Board because there isn't a rule that needs to be changed to help effectuate these reductions. So with that, I'm going to turn it to Bonnie and the next slide for a discussion specific to long-term services and supports.
Thank you, Adela. Hello, Madam Chair, members of the board. Thank you so much for allowing us to have this presentation this morning. My name is Bonnie Silva, and I have the honor of serving as the Director of the Office of Community Living. That office is responsible for the administration, oversight, innovation related to all long-term care services for Colorado. So we serve cross-disability populations, all the community-based services, all the institutional care services. I think you're fairly familiar with my staff, and I appreciate the opportunity to be here. I'm going to talk a little bit about the context around some of the reductions related to long-term services and supports. I want to say, and Adela highlighted this, LTSS is a key cost driver for our state, and as it should be. as it should be. We have intentionally, as a state, made some really significant investments into these services, into this population. We understand that this care is essential for people with disabilities, their families, and the community of providers that support them. However, when we're looking at the trajectory of expenditures that we are seeing now and the state fiscal crisis that we're in, we have to be part of the solution and coming to the table to say, how do we as a state live within our cost envelope? And how do we do that in a strategic and measured way so that we have better predictability in our budget? We can see that just from fiscal year 23-24 to fiscal year 24-25, the cost of care for LTSS has increased by over $1 billion. So we have to have some reductions on the table. And our hope is that we're able to make some strategic reductions in a way that helps us control the trend, but keep in place services, keep in place eligibility, make sure that we're not dismantling the payment infrastructure that we've worked so hard to invest in. I think it's important to note that over those last several years, we've seen increases go as high as 20%. And though when we're looking at what is driving that, because we serve people with incredibly complex care needs across that continuum, it's not necessarily the medical care for people that is driving the trend. It is, in fact, long-term services and supports. And so for the reductions that will be before you for consideration and changes that will be before you for consideration, they really are aimed at making sure we can proactively look at where that trend is going up and have better predictability moving forward. If we can move to the next slide, please. This slide, I really don't love slides that just show numbers. Like, I'm a very people-centric person, but I think if you look at that red side, when we looked at, if we took no action for long-term care and said, state, figure it out, go to other cost areas, I would need to request in this year's budget $378 million ongoing. With the sustainability actions that we've put in place, that would reduce that number by nearly $162 million ongoing. But we are still requiring $217 million ongoing to continue to invest in this population and these critical services. So it is a top priority. I think we're looking at a way where expenditures have been not what we anticipated, to sort of bring them back in alignment with national standards and help us have better predictability, not just for this budget year, but for many budget years to come, to ensure that Coloradans have access to these critical care. Next slide, please. This slide just shows, so central to long-term care is community-based services. So home and community-based services. And this shows the growth that we have had from fiscal year 19 to fiscal year 25. And you can see that the top table there is our program specific to children. We did end up combining those first two programs, the children with life-limiting illness and the children's home and community-based service waivers, effective July 1st as part of our move to community first choice, which I'll talk about later in the ruled presentation. But we are seeing double, triple digit, quadruple digit growth in many. And some of that, for example, the Children's Habilitation Residential Program, where you see we've had a nearly 2,000% increase in enrollment. That's good growth, right? Like, that's growth that we don't want to stymie. There's changes that we made there that really stopped kids from being forced into the foster care system because they had a disability. It stopped kids from being sent out of state, away from their homes and their families. So that growth is something that we're quite proud of. It's also important to note that when you have smaller numbers, those percentages look bigger. And so, you know, take it with a grain of salt, but it's something to be proud of. And, you know, the other growth that, again, very happy that people have access to services, but that is unanticipated is the significant growth in our children's extensive services waiver. And we looked at how we projected enrollment growth for that waiver and what has happened, especially in the last year. It's really not statistically explainable in ways that we understand. And so you'll see, not today, but in the coming months, like there's actions that we're taking to better understand that growth and make sure that it's in alignment with our policies. On the bottom table, we have our adult programs. Similarly to children, we have seen growth across both enrollment and how much we're paying for services, which is, I think, also really important point to drive home. It's not just more people need services and Colorado needs to rise to that challenge, is we are seeing more people are needing services and the utilization of those services are far more than what we anticipated or planned for as a state. And so we have to contend with that. If we can move to the next slide, please. So Adela showed you a slide of like, hey, we can see utilization and, enrollment or cost drivers. So this is in long-term care specifically. So we have been monitoring these trends for many years now. It's something we do on an ongoing basis. We've seen them kind of rapidly uptick over the last year and a half, 2 years in particular, in ways that, again, have been surprising to us. But over the last several years, in addition to making those investments, we've also made more measured changes aimed at controlling some of this trend in a more strategic way. I'm going to be honest, those changes have not been super effective. And so what we're doing now with the budget proposals that went through the governor's budget via the executive order is really looking at how do we specifically target where we know we need to be more proactive. And again, some of these will be before you, some of these won't be before you, but it's important that you have a comprehensive picture of the actions that we're taking. So when we're looking at that utilization, one of the rules that I'm going to speak to today is the soft cap on certain home and community-based services. We are looking at a weekly cap on caregiving hours. I think you heard a lot of testimony last year because we did a preview for that rule. We're not talking about that rule today. We've paused that until the JBC takes action. We are looking at capping homemaker hours for legally responsible people. I'm going to talk about that rule today, and unit limitations for Community Connector. I'm also going to talk about that today. And that's because those are areas where we have utilization that we need to bring back into alignment with a pace that we can actually afford. And then you can see rate increases, right? So nearly 43% of our trend is being driven by rate increases. And this is so significant. Following the COVID-19 pandemic, we saw that the workforce was really competing for other low-wage industry jobs, and we had to keep up, right? We had to make sure that we were bolstering that workforce. We had to make sure that we were investing in wages. If we can have the most beautiful service package in the world, but if we don't have care providers, it doesn't matter. And so this is something that we're working really hard to keep intact, making sure we have, reasonable wages for the people actually rendering care is just a core value for us as a department. And I believe for us as a state. But certainly the 1.6% rate increase impacts this community, and the 0.75 that was on the table will also impact this community. But we did look service by service. Is there any other area where we are paying in a way that is out of alignment? And so the one area where we really couldn't justify the rate that was being paid based off other similar services is Community Connector. So you will hear a little bit more about that in the presentation today. And then, we are always have our thinking hats on, working with our community, working with national experts to say, are there other strategies we can consider? So the other things that, again, not for today, but for you to all have awareness is we're looking at developing group rates for long-term home health and CFC. We're looking at changing how we pay to better align with how the service is delivered. So instead of saying, we'll pay you up to 2.5 hours, we're going to pay you in 15-minute increments, because when we look at the data and how you're billing, it better aligns with how the service is being rendered. Again, working with that industry to understand how should this be rolled out. And then last but certainly not least, we are looking at enrollment and eligibility increases. So you can see that, we have a lot of enrollment changes, and again, not before you today, around how people with intellectual and developmental disabilities may access our 24/7 residential waiver, and really making sure, again, our North Star is how do we make sure people have access to the services they need? How do we not reduce eligibility? Narrowing sort of who automatically gets access to that, making sure that it is the people who truly need it the most, while also supporting people to understand the broad service package that is available outside of that. And then we also have the Community Connector age, which I'm going to talk about today as well in terms of enrollment and access to services. If we can go to the next slide, please. I think I'm going to hand it over to my colleague, Rachel Entrekin, to talk a little bit more about the regulatory framework in which we're working in.
Thanks, Bonnie. Hi, everyone. I am Rachel Entrekin. I'm the Legal Division Director here at Healthcare Policy and Financing. I wanted to talk a little bit about putting into context the cost-saving measures that we've been talking about both here at Medical Services Board and then also sort of throughout the state. The General Assembly started their annual session in January. And so you're going to hear a lot about what the General Assembly and specifically within the General Assembly, what the Joint Budget Committee is doing to kind of work through some of the cost saving measures that the department has been asked to propose. So back in August, the governor called a special session of the General Assembly because we knew by then that we would have some very significant impacts from the passage of HR 1 on July 4th, and that we would not be able to satisfy the state constitutional requirements for a balanced budget and to keep up with the Taxpayer Bill of Rights, which limits the amount of money that the state can keep from taxing. So the department was initially directed through a bill that was passed during that special session. And then executive orders that were issued through that Senate bill to execute 26 different actions to address the current state fiscal crisis. And as you heard earlier from Adela and Bonnie, because Medicaid and Colorado, one of the biggest cost centers, we account for a full third of the total dollars available for the state to spend. We were a big part of that solution. And so some of these actions that were identified of the 26 are actions that were meant to be taken for next fiscal year, for fiscal year 26-27. And for those folks who are less keyed into the state fiscal year, our fiscal year runs from July 1st to June 30th every year. So when we talk about fiscal year 26-27, we're talking about next year. If we're talking about fiscal year 25-26, we're talking about right now up until June 30th. Since we since we knew sort of what the view was going to look like in August, we started doing a lot of work. We have spent hundreds of hours internally to try and move forward with the directives that we received through the executive order and through that Senate bill. And we've been working with stakeholders and we have been working to operationalize these actions, either through rulemaking with you all on the Medical Services Board, and then also with stakeholders, with our partners, with the public, with members and advocacy groups. On January 30th, there were several actions that were intended to start during this fiscal year. Those went in front of the Joint Budget Committee at the General Assembly through what's called the supplemental process, essentially asking the Joint Budget Committee to consider things that we need to do. We call it a supplemental process. That supplemental process can also end up with reductions, not just expansions in funding. And so some of those actions were approved. Those require rules. You'll see some of those today. You'll see some of those in the near future. And all of the ones that you'll hear about today have an April 1st effective date. And what we're trying to do is make sure that we have enough time to get those rules before the Medical Services Board for your consideration, and then be able to make those work in the community. So work on trainings, work on other kinds of things that need to happen in order for those changes to move forward if approved by the board. Some of the rules that you heard or actually were before you over the last month, a couple of those have been tabled. So the 56-hour rule that you heard a lot of testimony about during public comment, but you did not actually consider the rule itself, that has been tabled for now. As well as the IRSS rate change. That one has also been tabled for now. So you will not hear about either of those today from the department. And so for some of those, we are pausing any implementation until we hear back from the Joint Budget Committee about their determination of kind of where they want to go. The General Assembly, as you know, with Congress at the federal level, they hold the power of the purse. So it's ultimately their decision on some of these changes. If we could move to the next slide, please. One of the things that I know we've heard a lot about is why some of these rules are being brought before Medical Services Board as emergencies. So rules can be brought before Medical Services Board. We talk about regular rules and emergency rules. Regular rules are the rules that follow the Administrative Procedure Act in terms of notice and comment. Those rules can usually take between, at the fastest, between like 3 to 6 months between stakeholdering and noticing and getting those rules together and bringing them before the board for your consideration. Emergency rules can happen a lot faster. Emergency rules typically cut out some of those requirements from that Administrative Procedure Act process. So I want to explain a little bit what the timeline was and why you're seeing, yes, changes were made at the end of August through Senate Bill 25B-001. Between August and now sounds like a long time, but in fact, the time frame that we have had to spend the many hundreds of hours that we spent trying to figure out what would be the least worst option. Bonnie, I'm channeling you. The least bad option that we had on the table for some of these items, that all of that work happened very, very quickly, but a ton of staff time went into it so that we could make sure that we were making the best choices we could in the constraints that we had. The other thing too, though, is so policy making takes time, I guess, is the bottom line for what I was just saying. In addition to that, though, there were changes that we could not announce to the public because nothing was final with the governor's budget until October 31st. So some of those we've had very little time to sort of engage with the public and talk about other things we've been talking about with the public since before this fiscal year started. So in August of 2025, just looking at the slide for a minute, we've talked about that special session, the executive order that was issued by the governor in response to Senate Bill 25B-001. And then some of those changes that we talked about were announced right away, and we started working on stakeholdering right away. Then starting on October 31st, like I said, the governor's budget was issued. And then unfortunately, we also had to look at a second round of reductions because we knew at that point that the first round of reductions that we had been working on would not be sufficient to be able to close that budget gap. And we are one of the states in the country that has a balanced budget requirement in our state constitution. So we don't have an option there. Then, throughout this entire time, we've been working on external engagement, working with partners, working with the public to understand sort of what the views were, what the concerns were. We incorporated a lot of those concerns, questions, and comments into the rules that you're going to see before you today, which Bonnie will talk more about as we move forward with the rule presentations. And then, of course, what you've seen last month and this month is the actual presentation of some of those emergency rules. At the same time, I think there was a lot in the press about, for example, the IRSS rule did not move forward to a Medical Services Board vote. At the same time, I think a lot of folks were hearing in the press that HCPF had issued operational memos to case management agencies. And there was a view in some of the media coverage that essentially HCPF had gone around the board's decision not to vote on that rule. That did not happen. So I just want to make very, very clear what was happening at the same time that we were moving forward with the rule presentations. We also needed to make sure that we had resources in place. If the board adopted that IRSS rule, for example, we needed to make sure that our case management agencies were ready to make those changes starting April 1st. But I want to make really clear, if the board had voted no on that proposal, or, it did not move forward, then those kind of preparatory planning things would get shelved and they would be set aside. April 1st, they would not go live. So I just want to reassure folks that to the extent there was some kind of an appearance that we were ignoring the board's take on the rule and decision not to move forward with it, that was not true. All right, so then also in the last couple of months, we've been meeting before the Joint Budget Committee in public session for supplemental hearings, and that has continued. We've continued to work with the the Joint Budget Committee and the General Assembly very closely. And so last but not least on this slide, I think what we've talked about is a lot of the changes that you heard about before were slated to go forward on April 1st. Those are going to be put on pause, of course, until the Joint Budget Committee makes a decision on those, which could happen before April 1st, but we'll find out. And then you'll hear about from Bonnie about some of the emergency measures today that the Joint Budget Committee has in fact approved. Next slide, please. And then I want to focus a little bit more on the work of the board. I think one of the things that we've heard a lot about from the public and from board members is sort of who gets to decide what's an emergency rule and what's not an emergency rule, what's different about an emergency rule and a regular rule. So I just wanted to touch on that really quickly. So I've mentioned the Administrative Procedure Act a couple of times. That is a statute within the Colorado Revised Statutes. I have a citation here that you're welcome to look at, but I'm not going to read it. But most importantly for this group, I want to focus on what it means to be an emergency rule. An emergency rule can be moved forward if immediate adoption of the rule is imperatively necessary, either to comply with a state or federal statute or a federal regulation, or for the preservation of public health, safety, or welfare. That's a lot of what we're focusing on here because the budget does in fact actively impact public health, safety, and welfare. And of course, we do have changes in federal law that are directly impacting our budget. And we can do that where compliance with the requirements of the APA with that sort of longer notice and comment period would be contrary to the public interest. And in this case, when we look at public interest, what we're talking about is the ability to make sure that we can balance the budget. Because if we can't balance the budget with active engagement from Colorado Medicaid, we're going to be balancing the budget, not we, the General Assembly, will be balancing the budget somewhere else. And so that is a practical consideration in all of this. And I think one of the questions that also came up over the last few meetings was, who decides what qualifies as an emergency rule? And I do want to say this is really from a legal perspective, there is sort of the ultimate decision maker. And if I get this wrong, Jen, please correct me. The Solicitor General at the Colorado Attorney General's office will look at the emergency basis that's included in the public documents that you all receive as part of the rulemaking process. And we'll look at the rest of the record as well. But there is initial input, feedback, advice, both from the legal division, that's my team, and then also from the Attorney General's office. So these rules are thoroughly vetted before they come to you as emergency rules. So I wanted to just share that with you all so that you could understand when you're seeing an emergency rule from a legal perspective, those have been looked at, they have been vetted. And you'll hear more about the emergency basis, not just in the what we call the OP pages that you all receive as sort of the basis and purpose of the rule, but you'll also hear about it in the presentations that you will hear from Bonnie today. So I wanted to share that with you all so that you're familiar with it. And that is the close of the presentation for now. I guess the one thing I did just really want to focus on too is we know these are really hard decisions that we're asking the board to consider. And I think the public and the board have been understandably concerned and maybe confused about sort of how these rules fit in with the larger cost savings measures that are happening. But I do just want to make sure that that you understand that we want to make sure you have as much information as possible to make these decisions going forward. To the extent you have questions, I really encourage the board to just continue to be active in the way that you have been, asking questions and getting the information you need before making a decision. So I'm going to pause there and see if there are any questions from the board.
I have 2 questions.
Thank
for
you, Hick Puff. Do I hear questions from the board? I hear JK, were you already talking, sir?
I was. Thanks.
Great. I also do have hands up in the gallery. So after JK goes Dr. Martin. Go ahead, JK.
All right. This is JK Costello. These questions are for Adela. What is other? Takes up a lot of money, and it's other lab imaging, stuff like that.
Yeah, exactly. It's labs, imaging. Let me go back to that because I have the tiny print on there somewhere.
Oh,
We asked for a stick because we thought that would be a question.
Yeah.
others usually like at the bottom.
Yeah.
It's-
It usually is, but it's because it has a bunch of other things in there. It includes our managed care capitation payments as well. So that's also going to be, a big other, that's dental, labs, imaging, managed care.
So that's not so managed care is not in behavioral health. Oh, you're managed care for Prime and
Managed care, like the capitation payments that we're sending over to the Rays and to, for care management and that kind of stuff.
procurement.
Yeah.
Second question. Outpatient psychotherapy. So that's a Ray cost. So putting prior authorization on that, how does that save the department money? It's their money, right? The Rays under their capitation.
And they are working on trying to manage that, but through statute, a couple years ago, the legislature removed our ability to par outpatient psychotherapy.
Okay.
And we did not put a fiscal note on that because we thought, it would be okay. But what we saw was a massive spike in utilization that may not be consistent with actual medical necessity. So that's the concern there. But that one does need a statute change. And so that has to go to the legislature at this point. And the Rays are looking at how they may better manage their own contracts within the constraints that are in statute.
But for this year, their funding's set. If there's more outpatient psychotherapy, does that raise their capitation payment for next year?
Yeah, so any changes, utilization increases or, maybe decreases get built into next year's capitation payments. And then if there's something extraordinary that happens, sometimes we're in a position that we have to reopen those contracts for rate negotiations. So yeah.
Okay, thanks.
And Madam President, this is Rachel Entrican. If I could just make one quick comment about that as well.
Please do. Thank you, Rachel.
Thank you. So one thing about the work that we are proposing on those prior authorizations, JK, prior authorizations would kick in after, at this point, the proposal is after 26 sessions. So prior authorization would not start at 0.
Okay.
All righty. I've got Dr. Martin next. Go ahead, sir. I cannot hear you talking, Dr. Martin. Kelly, is there anything we can do for Dr. Martin? I am not hearing his voice.
Unfortunately, yeah, we're having trouble with you there.
All right. would it make sense, do we suppose, IT team, to have Barry come off and back on to the call? I can see him coming off mute and his mouth moving. I'm just not hearing sound. Is that what you guys are having in the room also?
Can you hear me now?
I hear you now.
Yay.
Hi. Hi, Dr. Martin. Go ahead.
Hi. Sorry about that. So my question is sort of how you all approach this issue with spending. So we know that in a lot, or in my experience, in a lot of healthcare spending situations, about 20% of the people who are using services account for 80% of the cost, and the top 2% or so of people receiving services can account for as much as half of the cost. So when we think about how do we rein in some of these costs, one option is to go for the high utilizers since they account for so much of the spending, but they're also the most needy, as opposed to the broad number of people who don't spend a lot, but are less needy than the very top. And so it seems to me if when you put a cap on services, you're mostly affecting the highest need recipients. And it's tempting to do that because that's where most of the money is, but they are the most needy, as opposed to example, if you tightened entry requirements, you would be serving fewer people, saving less money, but those are people who don't absolutely require the services as much as the highest tier. So I'm wondering how you all think about those cuts in those ways, given the high utilizers, high need people, and the lower utilizers.
Bonnie, Bonnie, are you looking to answer? You're showing on mute.
Yeah, I am looking
Well, that's weird. Your showing is muted, but then I could hear you. Very weird stuff going on here.
It is.
All right.
I'm Zoom audio, Madam Chair. Dr. Martin, it's an excellent question. And you can imagine in my area, like we only serve high need people, right? So I think it's important to understand that when we're looking at how we create a sustainable budget, we have to look at how we can control our trend. Again, not this year and in the out years. So across some of those strategies that I just gave a high level overview at, they're really aimed at where utilization is maybe not in alignment with what we had anticipated, and maybe not in alignment with our policies, where we needed to have additional sort of parameters proactively in place to make sure that the services are being authorized in a way that we intended. But I also think what's essential is that we serve people with very unique needs. So we also have exceptions processes in place to make sure that if an outlier is an outlier because their needs truly support it, we have a way to make sure that their needs continue to get met. So I think both things can be true. If we did a across the board rate cut, right? Just to let's solve our fiscal woes in one foul swoop, that would be far less controversial. It would probably feel really good in the moment. I know it would to me and my staff. And the trajectory of spend would continue, and I would be back at this table next year with far deeper and more significant cuts because our budget hole would get even bigger. So know that the people who have the most needs are top of mind for us as we're looking to implement many of these changes and making sure we have the right safety nets in place to catch them, while also ensuring that our future selves are not looking at making more catastrophic and difficult decisions because we didn't sort of rein the policies in to where they needed to be.
Can I ask a quick follow-up question?
Go right ahead, Dr. Martin. The floor is still yours.
So the other thing I wonder about for these people who are very high need and high costs is if there's a cap on their services, will some of them have to end up in even more costly alternatives, I don't know, regional centers or nursing homes or other more institutional and more costly systems because the families can't care for them anymore?
Yeah, thank you, Dr. Martin. That's a great question and one that we receive a lot. So one, again, we are going to have processes in place to meet people with exceptional care needs where they're at. It is not beneficial to the state to create policies that drive towards institutionalization. And I think that you can see that our data supports that that doesn't happen, right? We really have comprehensive community-based care strategies in place. And the criteria to get into higher levels of care, whether that's a regional center or a nursing facility, are really narrow. And we do a lot of work to proactively mitigate that. So I think what's essential is we're moving forward with these changes to better ensure sustainability is the monitoring of the implementation of those changes to ensure that we're achieving the goals that I just highlighted for you.
Thank you.
I see Dr. Kennard's hand next.
Good morning. Can you hear me?
I can, Dr. Kennard, go ahead.
First of all, it's clear that the team really put a lot of effort into that presentation and trying to help us be good decision makers. My comment and a question. I think what gives a lot of us pause as we've been on the board a little while is as we contemplate cuts, which we understand have to happen, it's in a context of stories that we keep hearing. In the last year, we've heard of horrible overuse of non-emergent transportation, of the contact lens benefit that just suddenly blew up a few extra $1 million, and the comprehensive drug testing, which I never would have understood if JK hadn't explained to us. So those are just three areas where we saw big time opportunity that was not understood in real time and only after a lot of money had been spent. And so I think the team has to realize that as board members, those are on our mind as we contemplate further cuts. And I think I personally, and I suspect we all do, kind of need reassurance that there is renewed effort to identify those things before they become those big spending sinks. And then getting to my question, with regard to the community, as an example, with regard to the community connection benefit, which I think I'm understanding is somewhere now in the $60 to $70 million a year range. And it's a program that 47 states don't have. So my question is data related. Is there any data that suggests our $60 plus million investment has had that effect of decreasing utilization of hospitals and other institutional settings? I find that a very interesting. We didn't know that until someone's mailed it out this week that we are one of 3 states that has that program, which I found very interesting. So that's my big question. My other plea is, please, the use of percentages when you're describing increases can be confusing. Like, what's the difference between a 100% and 200% increase? I actually don't think I'm not sure, but I'm pretty sure that's not mathematically appropriate to do that. So I really don't know the difference between a 100% increase. Is that a doubling? And if that's a doubling, what's a 200% increase? So small point, but hopefully someone will answer that. Big question is, what is the community connection investment? As an example, how do we know that's actually a good investment?
Bonnie, I see your hand up. Were you looking to respond to Dr. Kennard?
Yes, thank you, Madam Chair, and thank you, Dr. Kennard, for your question. And I'm happy to go more in depth when I present on the rule changes related to Community Connector. The short answer is our data would support that Colorado is wildly successful in keeping people in the community. In fact, we're one of the top performing states in the nation. Our ability to directly link that to Community Connector, well, I think the story with all HCBS services, correlation versus causation. There's a lot of correlation there. So I'm happy to go more in depth when I present that rule, talk to you about how we've monitored the data over time, the changes that we've made, and why we've ultimately landed with the proposal that we have on the table for today. And then in terms of percentages, thank you. We always vacillate between giving real numbers and doing percentages and what is more impactful for people. But it is a doubling and then a tripling and then right. So as we go up, if it's a 200% increase, and that's a tripling of the original one, just trying to, in a snapshot way, articulate the growth that we're seeing. So thank you for your questions.
That was Bonnie Silva speaking. Do I have any other questions from the board? Okay, I'm hearing none. Wow, that took an hour. Thank you. I feel so much more in the loop than I did before this. We are totally grateful, but I think I'm going to do our first quick 5-minute recess here. Let us all take a minute and then we can start with rulemaking. So I am calling a 5-minute recess. Welcome back, everybody.
Welcome back.
No.
Hey, everyone.
Thanks. Thanks, you too. Bye. We all back.
All righty, team. Thank you again to the Hickpuff team for a very informative presentation. I don't think it could have come at more appropriate time. We've really all needed to get on to a similar page. So thank you. Thank you, all three of you, for taking the time to really knock that home for us. And with that, team, I will take an approval of January's minutes if there was someone who would like to motion.
This is James McLaughlin. I make a motion that we approve last month's minutes.
Very good.
Second.
Thank you very much, Cassie. All in favor, please say aye.
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 Aye. All opposed? Abstentions? Very good. We have approved the minutes. All right, team, we are on to final adoption by consent. Last month, we had 5 rules that we put on to consent. Is there anyone on the team that feels that any of these need to come off consent? Was that just a cough?
It was, sorry.
That's okay. I just wanted to make sure that I wasn't missing anybody. All right, if there are none that seem to come off of consent, I would entertain a motion to approve those 5 rules, please.
This is Barry Martin. I can do it.
Thank you, Dr. Martin. Go ahead.
Move the final adoption of document 1 MSB 25-07-01-F, revision to the Medical Assistance Act rule concerning federally qualified health centers, section 8.700.6.B. Document 2 MSB 25-11-20-A, revision to the reentry services for incarcerated individuals, section 8.100.3.G.B.2, or II. Document 3 CHP 25-12-01-A, revision to the reentry services for incarcerated individuals, section 120.1.C and 210.U. Document 4 MSB 25-10-07-A, revision to the Medical Assistance Act concerning pharmacy reimbursement methodology update, sections 8.800.13.B, 8.800.13.C, 8.800.13.H, 8.800.13.I or 1, I'm not sure. 8.800.13.J and 8.800.13.K. And document 5 MSB 25-09-03-B, revision to the mental health transitional living home, sections 8.753.2A through G, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Dr. Martin. May I have a second, please?
This is James McLaughlin. I'll second.
Thank you, Mr. McLaughlin. All in favor, please say aye.
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 I
All opposed? Abstentions?
I abstain. It's J.K. Costello.
Thank you, JK, for calling yourself out. That makes my life so much easier. And with that, document 6 passes. And I'm sorry. Yeah, I'm sorry. That was, I beg your pardon. That was emergency rules. Those are consent rules. Those all passed. I'm sorry, you guys. I was on the wrong page of my stuff. Let me start over. And with that, the final adoptions by consent all pass. I am now on the same page. Please forgive me. I am human. And with that, we are going to go on to final adoption. This will be our second hearing of document 6. And with us today, we have Corey Conolog. Good morning, Corey.
Good morning, Madam President. Alrighty. Good morning, Madam President and members of the board. My name is Corey Conolog, and I'm the Pharmacy Policy Specialist for the department. I'm presenting document 6, MSB 25-12-17-A, revision to the Medical Assistance Act concerning enhanced dispensing fee correction for parenteral nutrition, section 8.800.13.p. In October, MSB approved the rule establishing an enhanced dispensing fee for parenteral nutrition. And just to recap, parenteral nutrition requires highly specialized, individualized, prepared formulations that current dispensing fees don't adequately support. Senate Bill 25-084 authorized an enhanced dispensing fee to ensure pharmacies can continue to provide this critical therapy and maintain member access. The implementation of this policy also required a state plan amendment with the federal government. Following final adoption of the rule, which established the enhanced dispensing fee, CMS approved a higher rate than the rate that was published in October. This final rule brings the enhanced dispensing fee into alignment with the state plan approved rate. And this change resulted in an increase of $2.45 per prescription fill. Although the state budget crisis persists, the budget impact of this increase is expected to be minor. We've received positive stakeholder feedback on this rule change with no questions or concerns. So I kindly ask for a yes vote to ensure reimbursement is consistent with the CMS approved state plan, and will happily answer any questions.
Thank you, Corey. Do I have any questions from the board? Hearing none. Mr. Sykes, do I have anyone signed up for public testimony today?
This is Chris Sykes. I do not have anybody signed up for testimony on document 6.
Wonderful. Then I will accept a motion on document 6.
Madam Chair, this is Cassie Littler. I would move the final adoption of document 06 MSB 25-12-17-A, revision to the Medical Assistance Act concerning enhanced dispensing fee correction for parenteral nutrition, section 8.800.13.p, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, ma'am. May I have a second?
This is David. I second.
Thank you, Mr. Pump. All in favor, please say aye.
Aye.
All opposed? Abstentions? All righty, document 6 has passed. We are on to the initial approval of the portion of the program. We're going to start with document 7, and our friend Rachel Larson is with us. Good morning, Rachel.
Good morning, Madam President and board members. My name is Rachel Larson, and I am a compliance and policy advisor for the department. I'm here to present MSB 25-7-15-B, revision to the medical assistance rule concerning plan of care signature requirements. I'm joined today by Devin Parsons, Medicaid Benefits Policy Specialist, and Sarah Davis, Stakeholder Engagement Unit Manager, and they will both be available after this presentation to assist in answering any questions today. The rule proposal before the board today makes a few changes to Rule Section 8.200. First, there are a few technical updates, such as updating citations and removing incorporation by reference language and capitalizing terminology. Second, the word written is removed from written referral in the speech language pathology services portion of the rule because other therapies are not as restrictive in the language around orders and referrals. Therefore, the speech language pathology portion of the rule should align with the other therapies. This does not mean that verbal orders are authorized at this time. It just aligns terminology and level of detail in the rules. Finally, the main change presented in this rule package is the addition of terminology that aligns with a federal regulation, 42 Code of Federal Regulations 424-24C5. Though this is a Medicare regulation, there is not an applicable Medicaid regulation on this topic, so the Medicare regulation is instructive for the department. To summarize the new language proposed in the rule, signatures will not be required on a plan of care when there is already a written order or referral from the physician and the therapist has evidence the plan of care has been delivered to the physician's office within 30 days of completion of the initial evaluation. This rule change will apply to outpatient physical therapy, occupational therapy, speech language pathology, and audiology. Members will benefit from this rule change because there will be more flexibility on the signature requirement for certification of the plan of care, which will then increase timely access to care for members. Providers will also benefit by being able to provide care in a more timely manner instead of having the administrative burden of waiting for certain signatures before treatment can begin. The department conducted a written stakeholder engagement process on the proposed policy and collected feedback between November 3rd and December 8th, 2025 through an online feedback form and email submissions. Outreach included 3 targeted email campaigns to outpatient speech, occupational and physical therapy, as well as audiology providers, a notice in the November provider bulletin, and announcements posted on the occupational speech therapy benefit and outpatient speech therapy benefit, and outpatient physical therapy and occupational therapy benefits web pages from November 23rd through December 8th, 2025. There was broad support, and if there were any questions, Devin Parsons individually reached out to stakeholders with clarification and resolution. As mentioned, policy staff responded directly to stakeholder questions submitted through the form and by email, and all feedback and department responses are documented in the stakeholder log and comment summary for reference. Board members can access the stakeholder log and summary on the member website under the rule. Thank you for your time. We are open to any questions that you may have.
Thank you, Rachel. Do I have any questions from the board?
This is Amanda Jashinsky. I have a question.
Go ahead, Amanda. Good morning.
Morning. Rachel, can you please clarify, would the onus of showing the issue or referral be on the, for example, speech language pathologist and their program, or who would be responsible for showing that those referrals had been issued?
Thank you for that question. I'm going to kick this over to Devin Parsons, who's the policy specialist on this rule, and she may have further details.
Thank you, Rachel. Thank you for that question. This is Devin Parsons. Speech therapy falls under the OPR regulations, so an order is required for speech therapy, and that goes onto our claim submission. But essentially, the referral would have to happen in order for the plan of care to begin. So the speech therapist would just provide that plan of care back to the ordering provider. So does that answer your question?
This is Amanda Jashinsky. If I can just kind of talk back to see if I'm understanding correctly. So the speech language pathologist in this example would receive the referral and send back a plan of care, which at that point wouldn't necessarily need to be signed and faxed back, but a plan of care would still come back to the ordering physician. Is that correct?
Yes.
Okay.
Hi, this is Laura. Devin, you might want to check your microphone. It is a little difficult to understand you, which I think is part of the reason why your answer was spoken back to you. You're coming back kind of like a robot.
Thank you.
Yeah. Do I have any other questions from the board?
Yes, this is Amanda Jashinsky. Sorry, I have one additional follow-up question.
Please, the floor is yours until you are done with it.
Thank you. In the case where a physician receives a plan of care for a patient that they never sent a referral for, which has happened to me numerous times, because one of the things that we can do currently is not sign the order until we see the patient in clinic. For example, I've seen a patient sometimes for an acute visit. They didn't meet with me as their primary care provider. And then all of a sudden I start getting orders for their speech language therapy. I have contacted that patient and said, I'm more than happy to help you get these orders signed, but in order to do so, I need to understand that I'm your primary care provider and we need to have an establishing visit. So can you kind of explain how these, I understand that might be a one-off situation, but how we should be handling those in the community with this in place where the order doesn't necessarily need to be signed.
This is Devin Parsons. Are you saying that do you mind repeating that question? I don't think I understand the scenario.
So occasionally we might have encountered a patient for an acute visit. But they weren't, I apologize, this is Amanda Dushlinsky. There have been situations where I've encountered a patient for a visit, but they have not established with me as their primary care provider. And then a couple months later, I start getting orders to sign for example, speech therapy, but I never discussed expressive speech delay with that patient because they were not established with me. I was not their primary care provider. We did not discuss everything. In the past, I have held off on signing any orders until I fully understand what I'm signing and that I'm the primary care doctor and so forth. In what my concern is that if I am listed as the primary care doctor by the patient, for example, and there is a record of me having interacted with the patient and the order plan starts coming over, but without room to sign and send back. How would I just be contacting the agency directly if I didn't want to be listed on the order? Like, how do I avoid having orders placed under my name automatically that I'm not comfortable with?
This is Devin Parsons. Sorry, I turned my camera off. Chris said it might help my audio. So the order would need to be signed initially, but I'll let Rachel hop in here in case I'm misspeaking. The way that we wrote the rule is that the physician who is signing the plan of care would need to have knowledge of the case. So if that was something that you were uncomfortable with, I can't speak to that portion.
Yeah, this is Amanda Dushlinsky. I guess that's my concern is that it happens a lot where there are cases, there are orders, there are plans of care that come to our office that we do not have knowledge about.
This is
and then we work with the agency and also with the family to kind of communicate and find out, was this sent in error? Does the family want to establish care with us after we can start signing these orders? I think it happens different, physicians might have different experiences, but I do know that it happens. And so I'm trying to figure out how this would be prevented.
This is Rachel Entrekin for the department, if I may, Madam President.
Please.
Thank you. This is really important feedback for us to hear. I'm not sure our team has had a chance to look at that particular issue.
Okay.
We'd like to take it back and talk internally about it so that we make sure that we're accounting for the situations where that happens. And it sounds like I'm seeing body language in the room that for folks on online may not see, but it sounds like this is not infrequent for you or for Dr. Littler.
This is Dr. Littler, Cassie Littler. I would agree with Amanda. Many times patients are continuing to get services and maybe have not followed up in a timely manner within our practice. And so maybe they were seen a year ago, they continue to get services, but we have not seen them. They're maybe not attributed to us any longer. And so we will hold off on signing those plans of care to say you need to be seen, in order to continue to receive these services. It's also just to make sure that kids are okay and that they continue to really need these services. I appreciate the effort to try and stop the administrative burden of signing all of those plans of care. But my question that I was going to ask was, is there going to be anything to look at the impact of this? Like, is utilization going to be monitored, or as a cost center with a change such as this? Because I agree, I do maybe hold off on signing something until we can reach out to a family if they've not been seen in our practice.
This is Dr. Amanda Jashinsky. If I may just add one additional point to Dr. Littler's excellent point. I would also say this helps us ensure that if, for example, a family has transitioned to a different primary care office, that office starts receiving the orders and plans of care appropriately. It helps with the communication between practices. And I do worry about just like faxes coming in and not, that transition not happening appropriately if the family decided to elect to get care elsewhere or so forth. So, yeah.
Thank you. I don't know if Devin's audio is working at this time, but Devin, did you want to talk about the utilization piece?
Yes, this is Devin Parsons. I will second Rachel's comment that we'll definitely take this back. This isn't feedback we had necessarily received before, and it's super helpful to hear. We do track utilization internally. We do management reports quarterly and look in depth to just trends that we see. So we will absolutely be monitoring that.
This is Cassie Littler. I just had a question about the utilization trends.
Cassie, I'm sorry. I do hear you asking a question. Mr. Pump has been sitting with his hand raised very, very, very patiently. So I'd give him an opportunity to jump in real quick.
Hey, thank you very much. This is Dave Pump. I just wanted to compliment the process real quickly. I am exceedingly grateful for how the department brought this data forward onto the platform and the portal rather, and how we can see the feedback and the prep in the language for this particular rule. I think it's fantastic. What I applaud even more is that the Medical Service Board is looking at this and saying, hey, I'm looking at all that feedback and I don't see any stakeholder information from from medical providers who this rule would also be affecting. I'm just looking and seeing a lot of feedback from therapists, which is awesome and wonderful. And having waited for PCPs to sign off, it's infuriating sometimes, that delay, and I get it. But there's value to that, and I'm exceedingly grateful for this conversation. This is exactly how this should work. So thank you very much.
Thank you, Mr. Pump. I am happy to go back to the room.
This is Cassie Littler, and I'm happy to give stakeholder feedback in a different venue if this is helpful. But just thinking about patients who are getting therapy services through this way and overlapping what types of preventive care services they're receiving, within their medical home, that data might be impactful and helpful for future, looking at cost centers.
All righty. Do I have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on document 7?
This is Chris Sykes. We have Bryce Rafferty.
Good morning, Mr. Rafferty.
Good morning. Can you hear me?
I hear you just fine, sir. The floor is yours for 2 minutes.
Good morning, Madam Chair, members of the board. Thank you. I would actually like to defer and yield my time back. I will be commenting on document 9. I apologize for the confusion.
Mr. Rafferty, I appreciate you yielding that time back. As I'm sure you can imagine, we'll take every minute we can get. Do we have anyone else signed up for public testimony today on document 7, Mr. Sykes?
This is Chris Sykes. We do not have anybody else signed up for document 7.
Very good. Then I will accept a motion on document 7.
Madam Chair, this is James McLaughlin. I can make.
Oh, wait, you know what? I see, one moment, point of order. I apologize. I see Rachel Larson, the presenter, with her hand up, and I wanted to give her an opportunity there. I apologize, Mr. McLaughlin, hang tight.
That's okay. Thank you very much. This is Rachel Larson from the department. I just want to clarify in the language at 8.200.2.f, it does state that that the initial order needs to be signed by the physician. So hopefully that's understood under 8.200.2.f, point 1, point A, point 2 little I. I know that's very detailed in how this rule is written, but it does go over the fact that there's an initial order that has to be signed from the physician, and then then at that point the plan of care cannot have a signature, and as long as it's transmitted back to that physician's office, the one who did the initial order. I think what I'm hearing is that there's concerns about who's monitoring what the who did the initial order and what it covers. Is that what I'm hearing?
This is Amanda Jastrzynski. Yes, that would be helpful. So if the initial order needs to be signed, I think that that's helpful. And then, yeah, I apologize if I missed it in this very long rule, but is there also additional, like, does it have to be re-signed yearly? Is there any additional monitoring that takes place, or once it's signed, it's good indefinitely?
There is recertification requirements that we didn't even touch. I don't know if you want to go over those, Devin.
Yeah, this is Devin Parsons. Recertifications still need to be signed and reviewed. So we haven't touched anything in regards to recertification. This is just specific to the initial certification, but the order must be signed. But the plan of care rules for recertification stand and have not changed.
Okay. This is Amanda. Thank you for that clarification. That's very helpful.
I do want to, this is Rachel Larson one more time. Just want to see if that cleared up some of the concerns that were voiced earlier, or if you believe that the department would need to take anything back.
This is Amanda Jastrzynski. In my opinion, that clarifies the concerns, and no, I don't think it needs to be taken back.
Okay, thank you.
Rachel, you're good. Thank you for jumping in on that. It sure makes things easier for me. It's all about. All right, and with that, let's try a motion once again for initial approval of document 7. Is that still you, Mr. McLaughlin?
Absolutely, and this is without reservation. Thank you,
The
everyone.
floor is yours.
Thank you, Madam Chair, James McLaughlin. I move the initial approval of document 07-MSB 25-07-15-B, revision to the Medical Assistance Act rule concerning plan of care signature requirements, incorporating the statement and basis and purposes and specific statutory authority contained in the records.
Thank you, Mr. McLaughlin. May I have a second, please?
This is Amanda Jastrzynski. I second.
Thank you, Doctor. All in favor, please say aye.
Aye.
Aye. All opposed? Abstentions? Splendid. Document 7 passes its initial approval. Thank you, team. We are now on to document 8 with Tracy Gonzalez. Good morning, Tracy.
Good morning, Madam Chair and members of the board. My name is Tracy Gonzalez, Finance Unit Administrator with the Special Financing Division. Today I'm presenting MSB 25-07-15-A, proposed rule revision to the primary care fund to align with statutory changes enacted through House Bill 25-1288. Daniel Harper, the Finance Unit Supervisor, is also on the call, and he'll help assist with any questions at the end of the presentation. Next slide, please. The Primary Care Fund was established in 2005 through House Bill 05-1262. The program awarded funding to clinics that provide comprehensive primary care services to low-income uninsured individuals across Colorado. Currently, the program is funded through a combination of the tobacco tax revenue and the federal match. Next slide, please. House Bill 25-1288 was signed during the 2025 legislative session. The bill authorizes the department to accept gifts grants, and donations from both public and private sources to support the primary care fund. This change expands the type of funding sources that can be used to support the program. Next slide, please. So while statute now allows the department to accept gifts, grants, and donations, the current primary care fund rule does not reflect this authority. The rule revision is therefore necessary to align the rules with statute and allow the department to implement this new funding flexibility. Next slide, please. The proposed rule revisions include updates to the general description of the primary care fund and the addition of gifts, grants, and donations as allowable sources for payment. These changes clarify funding sources and ensure consistency with the new statutory authority. The primary care fund payment structure will not change. Next slide, please. These rule changes will allow for additional funding options for primary care fund providers by expanding funding flexibility. Healthcare centers will have more tools to bring in resources, which ultimately supports their ability to serve more individuals and improve access to primary care services. Next slide, please. The allocation of funds will stay the same. There'll be no increase to the state's budget, and there will be no additional burden on state revenues. All administrative work associated with the changes will be absorbed into the existing primary care structure. Next slide, please. I thank you for your time and consideration. Daniel and I are happy to answer any questions the board may have.
Thank you, Tracy. Do I have any questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on document 8?
I apologize, Madam President. JK has a question.
Oh, I'm sorry about that. I didn't see or hear you, friend. Go ahead.
It's okay. I was waiting for somebody else to ask a question. So this is Jake Costello. My understanding is that this will provide, so in addition to the 19% tobacco tax that goes into this, they could solicit gifts or grants or donations that would add to the volume of the primary care fund. Is that right?
This is Tracy Gonzalez. Yes, that is correct.
Okay, and this is also Jacob Costello. Where do you have an idea of what those are? It sounds like the people who work on this primary care fund will solicit those. What are potential examples of these grants and donations?
I will throw that over to Daniel Harper if he is unmuted.
This is Daniel Harper. I've unmuted. Hopefully you can all hear me. Some examples of that would be similar to the Provider Stabilization Fund, gifts, grants, or donations raised by the Colorado Hospital Association. That's one example. The other would be, I'm sorry, that is all I can think of at the moment.
Does that answer your question, JK?
Yeah.
Wonderful. Do I have any other questions from the board? Hearing none. Let's try that again. Mr. Sykes, do we have anyone signed up for public testimony on document 8?
This is Chris Sykes. We do not have anybody signed up for testimony on document 8.
Wonderful. Then I will accept an initial approval motion for document 8.
Madam Chair, this is Cassie Littler. I move the initial approval of document 08 MSB 25-0715-A revision to the primary care fund rules concerning changes per HB 25-1288 section 8.950, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, ma'am. May I have a second?
This is Amanda Jashinsky. I second.
Thank you. All in favor, please say aye. Aye.
Aye.
Aye.
All opposed? Abstentions? Excellent. Document 8 passes initial approval. On to document 9 and our friend Nicolette Cordova. Good morning.
Good morning, Madam President and members of the board. My name is Nicolette Cordova. I work at the Colorado Department of Healthcare Policy and Financing within the Office of Community Living. Callie is going to be so kind as to put my presentation up for all of you. And I will get started.
Your presentation is already up, Nicolette.
Is it? Okay, great. Sorry, I couldn't see it on my end. All right. I am here today to present Document 9, MSB 25-07-02-B, regarding a rule revision that removes the determination of a developmental delay and intellectual and developmental disability requirements from the former 8.600 rules and relocates them to Section 8.7202. Point D, determination of developmental delay and intellectual and developmental disability under the Home and Community-Based Services, or HCBS, case management rules. This rule is part of the HCBS case management rule set and impacts individuals applying for HCBS waivers with intellectual and developmental disability, targeting criteria, as well as case management agencies and providers. Next slide, please. And for some reason, I can't see it, so I'm just assuming that every time I say that, it's going to come up. Let me know if it doesn't. The rule is being brought forward today to remove outdated and duplicative language from the former 8.600 rules and to consolidate the determination of developmental delay and intellectual and developmental disability requirements into 8.7200 case management section. This revision supports the department's case management redesign and improves rule clarity, organization, and usability by placing all related determination requirements in a single consistent location aligned with current practices. Next slide, please. So for the impact and summary, the department removed the determination of developmental delay and intellectual developmental disability, it's a mouthful, sorry, requirement from 8.600 and relocated to 8.7202.D within the HCBS case management rules. As a part of that revision, the department updated outdated terminology and references, clarified documentation and professional signature requirements, established clear timelines for submitting documentation and completing determinations, clarified who may request a determination, including legally authorized representatives, and standardized notification and record-keeping requirements. These updates are administrative in nature and intend to improve consistency and transparency for applicants, case management agencies, and providers. It's important to note that what this rule revision does not do, it does not change eligibility criteria for developmental delay or intellectual and developmental disabilities. It does not change eligibility for HCBS waivers and does not affect service delivery, benefits, access to care, payment structure, or funding. Overall, the department expects this revision to have a positive operational impact by providing clearer expectations, improved consistency, and more streamlined role structure while maintaining existing eligibility standards and services. Next slide, please. So before moving to stakeholder feedback, I'd like to briefly highlight how the updated rule compares to the former rule and provide a few concrete examples of what has changed. So the rule relocates that determination requirement from 8.600 and 8.607 into Section 8.7202D, placing them within that HCBS case management rule, where these functions are carried out today. The rule also updates outdated language and terminology. For example, the title Determination of Developmental Disability has been updated to Determination of Developmental Delay in Intellectual and Developmental Disability. And the references to the community center boards have been replaced with case management agencies. Throughout the rule, language was modernized to be clearer, more consistent, and more person-centered. In addition, the rule clarifies who may request a determination, explicitly stating that requests may be submitted by individual, a parent of a minor, or a legally authorized representative, which improves clarity for applicants and case management agencies. The update also consolidates documentation timelines, clearly establishing the 90-day submission period, the option for a single 90-day extension, and a maximum of 180 days, all in one place. Finally, the rule more clearly identifies signature requirements and qualified professionals who may provide required documentation, which supports consistency across case management agencies and reduces confusion during determination process. Next slide, please. Stakeholder engagement was conducted in August and September of 2025 as part of this rulemaking process. The feedback was generally positive. Case managers in particular valued the clearer structure, consolidated requirements, and updated language. Stakeholder comments were reviewed and incorporated where appropriate, and no concerns were raised regarding unintended consequences or any operational barriers. The rule was then published for public rule review, and a public rule review meeting was held on January 20th, 2026, where no additional questions, concerns, or feedback were received at that time. Following the public rule review on February 6, 2026, the department received 2 clarifying questions and responded promptly. The department accepted one recommendation to clarify language and provided clarification on the need to retain the other provision, which addresses the requirement for a medical professional signature on diagnostic documentation. While current regulations do not explicitly require a signature, the department has a long-standing operational practice of obtaining signed documents to support quality assurance and confirm diagnosis are made by qualified professionals. To improve transparency and consistency, the department is aligning the rule with existing practice by adding the signature requirements in the language. This rule revision has no fiscal impact, it is budget neutral, does not require new or additional funding, and presents no future year concerns. Next slide, please. I am happy to answer any questions. Thank you all for hearing me out.
Thank you, Nicolette. Do I have any questions from the board?
Dr. Kennard here.
Go ahead, Dr. Kennard.
Nicolette, I want to thank you for that presentation. I was giddy at the slide that you showed of how things are under the rule, old rule and new rule. And personally, I would ask that every presenter look at that slide and consider trying to imitate that for future rules revisions. That was incredibly helpful. So thank you for that.
This is Nicolette Cordova. Thank you. I appreciate that feedback.
Do I have any other questions or comments from the board? Hearing none. Mr. Sykes, I see we have people signed up for public testimony today on document 9.
This is Chris Sykes. We do. We have Maureen Welch.
Good morning, Miss Maureen.
Good morning. Can you hear me okay?
I can indeed, ma'am. Go right ahead.
Wonderful. Thank you so much for hearing my testimony today. My name is Maureen Welch. I live in Arapahoe County. I have an adult son, age 18, who has an intellectual and developmental disability and who is currently enrolled on the Comprehensive Developmental Disability DD waiver because of the youth to DD waiver transition that currently exists but is proposed to be taken away. I also have a company called Navigating Disability Colorado. I have over 700 people on my private educational platform to learn about Medicaid, and also 1,700 on my regular mailing list. I'm concerned about why this is happening now. I don't see a significant change in this, but I'm going to make my comments on the specific language. The term intellectual and developmental disability is something brand new in this section. And since that applies to my son, I'm okay with that. I do have a little concerns about item 13C. It removes the term individual plan and replaces it with the term person-centered support plan. And I just want to make a comment that as a consumer and an advocate in the community, that no one uses the term person-centered support plan. We all use the term SP or IP for individual plan or service plan. And I noticed that HCPF requested more money from the JBC to continue their work on the single assessment tool and the person-centered support plan in a November memo that they called the Colorado Single Assessment Tool Implementation. So I just want to make the comment that people in the community, I don't think are going to understand what that term is. So I don't know if there's a way to leave both terms in there, but it seems that the person-centered support plan is yet to be developed by HCPF and not really a common term used now. But I thank you for work on this this part of the rule, and welcome for any questions.
Thank you so much, Maureen. We always appreciate your input. Do I have a response from the board? Or I'm sorry, from the department. Let's start with the department.
Hello, this is Nicolette Cordova from the department. In response to that, yes, we are, as part of the case management redesign rules, and as we are updating all of those rules to, there were some that didn't all completely get moved over. There was some language that wasn't completely cleaned up from old to new rule. So that language is consistent with what we are trying to move forward with and maintain within all of the rules to make sure that it does stay streamlined, that is the language that we are going to be using and moving forward with, and that it will then remain consistent and throughout, like it'll be within all of the rest of the rules moving forward. So it's just kind of part of that cleanup work as well. You're on mute.
Do I have any questions from the board? Hearing none. Thank you so much for your time as always, Maureen. We appreciate you. Who else do we have signed up for public testimony today, Mr. Sykes?
This is Chris Sykes. We have Bryce Rafferty.
Good morning, Bryce.
Good morning again, Madam Chair and members of the board. This is Bryce Rafferty with the Colorado Cross Disability Coalition. This rule appears to primarily add and align language while keeping the underlying eligibility and determination framework largely the same. I do, however, have one very targeted recommendation for additional language. In subsection 9C on the bottom of page 3, the rule lists types of medical professionals who may sign neurological condition documentation. I would respectfully ask the department to consider enumerating registered nurses on that list. Given ongoing provider shortages, especially in rural areas, it would be helpful and appropriate to explicitly include RNs as authorized signers to avoid any confusion around who qualifies as other medical professionals practicing within the scope of their license. From a practical standpoint, this change would improve access without undermining clinical integrity. In the past, educators working with transition-age students have routinely relied on registered school nurses to complete and sign PMIP documentation. That approach is workable, timely, and consistent with the needs of students and families navigating eligibility and transition planning. Excluding RNs can create unnecessary delays when other listed providers are unavailable. In closing, added RNs to that list of professionals who may sign the PMIP would promote access, reduce delays, and reflect real-world practice, especially for youth in school and transition settings. Thank you.
Thank you, Mr. Rafferty. May I have a response from the department, please?
This is Nicolette Cordova. Thank you so much for that. I am going to kick this over to Kidron Backus.
Good morning. Thank you for that question, Mr. Rafferty. The requirement for the language that we use in this proposed rule is meant to align with our standard practice of looking at applicable physicians that can and have the licensing to sign off on specific diagnoses. So we really want to make sure that there's flexibility in our regulation to allow for as many broad physicians that can sign off on those typical diagnoses. We will definitely take that into consideration and identify if it would be appropriate to have this regulation language specifically add in RNs as a possibility.
Thank you, Kidron. Do I have any questions from the board?
This is Cassie Littler. I have a clarifying question about that. I'm wondering if the recommendation is about signing the form of an already diagnosed condition in which someone is looking at a diagnosis list, or if this is a question about an RN or what's here, other medical professional in under C number I, if that's making the diagnosis itself of the neurological condition. Does that make sense?
Yes, this is Bryce Rafferty with CCDC again. The request would be specific to that subsection in terms of signing documentation. And we would be requesting that not requesting that people not qualified to make neurological condition determinations be able to make those determinations. Simply that for the purposes of convenience and in the event that we don't have an enumerated listed professional, especially given the provider shortages or in rural areas or in schools, that there's no confusion about who may or may not qualify as a medical professional practicing within the scope of their license.
Thank you. This is Cassie Littler. I have a follow-up question for the department. I'm wondering about the terminology other medical professional. In many other areas, sometimes they're called qualified medical professionals. And and that's like specific to their practicing scope. So I don't know if that makes any difference.
So thank you for the additional clarifying questions. And so I think the most appropriate thing for us to do today, folks, is take this feedback and make sure that we circle internally, and we'll come back with what we're able to accommodate to provide more clear and precise language that would be helpful based on your feedback. Thank you.
That was Kidron Backus speaking. Did that answer your question?
It did. I guess if other medical professional means a qualified medical professional, that's fine. I'm just wondering. Happy. I mean, I appreciate this rule and happy to, consider it, continue to consider it.
Sounds great. Hey, Kidron, I just want to remind you to please identify yourself as speaking because it is part of the public record. Thank you very much. Do I have any other questions from the board? Hearing none. Thank you as always, Mr. Rafferty. Mr. Sykes, do we have anyone else signed up for public testimony today?
This is Chris Sykes. We do have 2 additional individuals signed up for testimony, but Kelly and I cannot find them in the webinar.
Can we call out their names right quick and see if they can identify themselves?
Certainly. We have Christine Wood and Valkyrie Schmidt. And we are having trouble finding them in the Zoom. You could can they raise their hand? I just did. Yes. Either individual can raise their hand.
We're going to give you guys about 10 seconds to identify yourselves, and otherwise we are going to move on. All righty, with that, I'm going to go ahead and move on. And with that, I will accept a motion for document 9.
I'll move, Madam Chairperson.
That JK?
Move the initial approval of document 9, MSB 25-07-02-B, repeal of 8.607.2, determination of developmental disability, and move to 8.7202.D with title Determination of Developmental Delay and Intellectual and Developmental Disability, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, sir. May I have a second?
This is James McLaughlin, Madam Chair. I'll second.
Thank you, Mr. McLaughlin. All in favor, please say aye.
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 Opposed? Abstentions?
This is Cassie Littler, abstain.
Thank you, Dr. Littler. With that, document 9 does pass initial approval. And let's go on to document 10 with Cassandra Sowers. Good morning, Cassandra.
Morning, Madam President and members of the board. My name is Cassandra Sowers, and I work in the Office of Community Living at Healthcare Policy and Financing. I'm here today to present document number 10, MSB number 25-07-01-E for the repeal of Comprehensive Life Review from 8.7202.B, Intake Screening and Referral. Next slide, please. The purpose of the rule repeal is to remove the outdated requirements, the interdisciplinary team to complete the comprehensive life reviews. The rule requires the completion of a comprehensive review of a person's life situation when they require assistance with challenging behavior to help protect their rights. This was previously required only for members enrolled in waivers for persons with intellectual and developmental disabilities. The rule is being repealed to align with current practices. CLR has not been required in practice to complete these reviews for several years, but the rule was never repealed to reflect the discontinuation of the requirement, but new rules were promulgated to align with the CMS Final Settings Rule at 10 CCR 2505-10, Section 8.7011. A through C. Next slide, please. The repeal of this section will help clarify requirements for providers and case management agencies and remove any confusing language. This repeal will not have any negative impacts on day-to-day case management functions, nor any negative fiscal impacts. Stakeholder engagement was completed with CMAs on July 8th, 2025, with no concerns from stakeholders. I would also like to add that public rule review was held on January 20th, 2026, and there were no attendees with feedback. The next few slides will provide a comparison chart and preview of the rule repeal. Next slide, please. Thank you. On this slide is a rule comparison chart showing what was changed and what is still contained in the rule, section 8.7202.8, formerly point 12, was moved up to point 8 and contains: the case manager shall make referrals to the regional center when individuals with intellectual and/or developmental disabilities cannot safely be served in a community setting and shall comply with regional center admission policy. This is an existing rule within intake screening and referral, in the intake screening and referral section, It was just moved up for formatting purposes due to the repeal. We did, however, receive feedback yesterday about the language, about the regional center referral language, and the department is willing and able to revise the language to address the concern that the current language repeal appears to require a de facto referral to a regional center. Next slide, please. And here you can just see a screenshot of the rule and what we took out. And then if you want to go to the next slide, you can see what is left, which is what was in that comparison chart on slide 4. And that is the end of my presentation. If you do have any questions, please let me know.
Thank you very much. Do we have any questions from the board?
Madam Chairperson, this is J.P. Costello.
Go ahead, Dr. Costello.
I heard repeal on the document.
Would you repeat your question,
I
Dr.
heard this is a rule repeal. On our documents, it says revision for document 10.
Cassandra?
Yes, hi, this is Cassandra Sowers. This should be repeal. However, I am going to kick it to Michelle Topgoff to clarify.
Michelle, are you out there? Hi, Michelle, I see you. But I cannot hear you.
Madam President, this is Rachel Entrekin, if I could clarify.
You know what? That would be lovely. Michelle, you are showing off mute, but unfortunately, we're not able to hear you. If you find a way to make that stuff work, please get our attention. Thank you. Go ahead, Rachel.
Thank you. That's a great question, JK. It is in fact a revision and not a repeal. There is a portion that is being edited out, but not a repeal of the entire rule.
Okay.
Thank you.
Did that answer your question, JK?
Yes.
Very good. Do I have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for document 10?
This is Chris Sykes. We do. We have Kathy Feber signed up.
Good morning, Kathy. We're going to put 2 minutes on the clock for you.
Thank you. Good morning, members of the Medical Services Board and HCPF. My name is Kathy Feber. I am testifying on behalf of Colorado Advocates for Adults with Intellectual and Developmental Disabilities regarding the proposed deletion of the comprehensive life review provisions. We are concerned about this proposal and think that We are concerned that this proposal and think that HCPF's proposal is inappropriate. Comprehensive life reviews happen when there's a change in a member's behavior that causes or threatens a disruption in their setting or services. The existing rule found at 8.7202B provides a vehicle for a complete review by the integral members of the team to intervene and determine whether there is a need for a change in supports or services for a member. As we all know, behavior is a communication, and when there is a behavior change in a member, we need to examine the root cause and determine how that adult can be best supported. HCPF proposes to completely delete this important process from the rules, stating that it is appropriately listed under case management responsibilities when, as a practical member, it is carried out by the provider agencies. Instead of deleting it, why not move it under the section regarding provider agencies' responsibilities? These reviews are important and should not be eliminated. We are concerned about this deletion. There is no companion provision, there is no companion provision in the provider agency provisions, and deleting the comprehensive life review provision would effectively eliminate it. We are concerned that HCPF is not moving this provision and is suggesting simply deleting it because they have proposed a number of regulations recently that will strip provider agencies of the power in helping to guide members to services and support that meet their needs. They have a proposed provision that has not come before you yet that will exclude provider agencies from the assessment process. And as advocates for adults with IDD.
Kathy, ma'am, I'm sorry. Thank you so much. That's time. We appreciate your testimony today. May I have a response from the department, please?
So this is Cassandra Sowers. Kathy, thank you so much for that testimony. I just wanted to clarify that we're removing the CLR requirements as the process has not been required in practice for several years, and new rules have been promulgated to align with the CMS Final Settings Rule 10 CCR 2505-10, Section 8.7001. Point A through C that provide the federally required protections for all members' rights, which do not require CLR for individuals with challenging behaviors. There's nothing that prohibits a provider agency from continuing to use CLR currently in place or from including that important information in the agency care plan for members.
Thank you, Cassandra. Do I have any questions from the board? Hearing none, thank you for your time today, Kathy. Do I have anyone else signed up for public testimony, Mr. Sykes?
This is Chris Sykes. We do not have anybody else signed up for document 10.
With that, I will accept a motion for initial approval on document 10.
This is Barry Martin. I can take it.
Thank you, Dr. Martin. Go ahead.
Move the initial approval of document 10 MSB 25-07-01-E revision to the Medical Assistance Act rule concerning comprehensive life review in intake screenings and referrals, sections 8.7202.B, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Dr. Martin. May I have a second, please?
This is Cassie Littler, I second.
Thank you, Cassie. All in favor, please say aye.
Aye.
All opposed?
Opposed.
I
This
hear
is
one
David.
opposed from Mr. Pump. Do I have any abstentions? All righty then, document 10 does pass initial approval, and with that, I am putting us in recess for 5 minutes, team. Thank you so much. Welcome back, everybody.
Hello, hello, we are all back.
Wonderful. And with that, team, we're going to go right on to document 11 and Christine Bates. Good morning, Christine. It's been a while.
Good morning. Yes, it has.
So nice to see you.
Thank you. You as well. So good morning, Madam President and members of the board. I'm Christine Bates, Supported Living Options Unit Supervisor with the Office of Community Living, and I'm here to present Document 11, MSB 250917C. The main purpose of this proposed rule is to expand the medical conditions that qualify residents for hospital backup unit placement to better align with current clinical standards. Hospital backup units, or HBUs, provide hospital level of care in a skilled nursing facility setting for members who are ventilator dependent, have complex wounds, or have other medically complex needs. Members eligible for HBU care no longer require acute hospital services, but continue to need 24-hour monitoring and life-sustaining technology. Residents must be approved for long-term care Medicaid. During the calendar year 2023, 1,559 members received care in an HBU. However, members with certain conditions were not eligible for HBU placement and often experienced prolonged and costly hospital stays as a result. Under certain regulations, HBUs do not cover, members with disorders of consciousness, certain neurological conditions, or complex bariatric needs. These rule changes present an opportunity for the department to improve access to appropriate care by expanding HBU eligibility criteria to include those qualifying conditions. Allowing these members to receive care in HBUs is expected to reduce unnecessary hospital stays and sometimes LTACs, while ensuring members receive the hospital level care they require in a less restrictive setting. In addition, HCPF has made minor updates to the existing 3 levels of care to better align the requirements with current clinical practice. But the most significant change in the regulation includes the addition of the 3 new medical conditions eligible for HBU coverage: the disorders of consciousness, complex bariatric conditions, and neurological disorders. The 4th level of care referred to as the combination level is also being added. This allows HCPF to review members who present with a combination of qualifying conditions that may not meet the criteria for a single category, but nonetheless require hospital level care and are appropriate for HBU placement. The per diem HBU rate is considerably lower than hospital per diem rates, and each transition from a hospital to an HBU results in savings. Based on current utilization and costs, the department anticipates savings of more than $1 million annually through shorter hospital stays and lower per diem costs. HCPF expects positive outcomes from the implementation of these rule changes, including improved access to care, reduced hospital utilization, and placement of members in more appropriate and less restrictive care settings. Our stakeholder engagement has been very positive. Thank you for your attention and review of these rule changes, and I'm happy to answer any questions you may have.
Thank you very much. I see Dr. Martin's hand up first. Go ahead, Dr. Martin.
Thanks. This is Barry Martin. This is just my own ignorance, I think. Can you tell us the difference between HBU and long-term acute care?
An LTAC?
Yes.
Yeah, so it's my understanding that an LTAC has is supposed to be short-term, if I remember correctly, and Richard Clark can correct me if I'm wrong, but LTACs are supposed to be more of a short-term stay, and they are for that even higher level of care than what would be in a nursing facility. And they typically don't take this level of care that goes into a hospital backup unit.
Did that answer your question, Dr. Martin?
Not really, but I can research it some on my own.
I can see if Richard Clark is available and can give us more detailed
I see Richard Clark in my mirror. Hello, Richard Clark.
Oh, thank you. This is Richard Clark. I'm the Complex Services and Supports Manager with Healthcare Policy and Financing in the Office of Community Living. What we're finding is that the LTAC stays, which are the long-term acute care stays, just tend to have a more acute care need that is higher level than what we're finding in the HBU system. So in order to transfer someone from a whether it be an LTAC or a hospital into the HBU, we're looking for a more stable condition. So when we're talking about like our ventilator patients, there isn't necessarily an acute need that needs the 24-hour physician, but there is a ongoing need for supports that are more appropriate or can be provided at the nursing facility setting. And in general, that's just a stable individual that's not going to have a emergent acute care needs that you might find in that LTAC. So between the whole spectrum here, we tend to have, the full hospital. People, as they improve to some extent, might move to a LTAC setting. And then from there, they can stabilize, go into a nursing facility. That LTAC step is not necessarily there every time, but it is on some cases.
Great, thanks.
That do you, Dr. Martin? Great. Dr. Kennard, I see your hand.
Thank you. So yeah, to also answer Dr. Martin's question, as a hospital-based intensivist, I can tell you there's certainly a population that there's not a good spot for them. And I see this as being a good category that can help decompress hospitals and put people in the most appropriate place. This is just my standard request for follow-up. It would be really nice to see a year from now, did this make an impact? Is this a real population? Is there 1,000 people that were saved 5,000 hospital days? It would be very exciting to see that data. So just a request for that. Thank you.
Yes.
Thank you, Dr. Kennard. Oh, go ahead, Christine. I'm sorry.
Sorry. This is Christine Bates. That is something that we are already tracking, Dr. Kennard, and plan to report out on a yearly basis. So thank you for that comment.
All righty. Any other questions from the board?
Madam Chair, James McLaughlin.
Go ahead, James.
Just a statement. This makes a ton of sense to me as somebody who started his career doing critical care transport in California. They've been doing some of this for a very long time, and I know how sometimes the restrictions can prevent patients from getting to those subacute levels of care that are more cost effective. And honestly, what I've really seen anecdotally in this patient population is doing that allows them to repatriate closer to their communities as well and reestablishes those support systems. So in addition to reducing cost, we're actually, I think programs like this help bring people closer to home more often than not. So I applaud this effort and really look forward to seeing those numbers as well. So thank you.
Thank you, James. Department, did you have a response?
This is Christine Bates. I just agree with that comment wholeheartedly, and we already see that. So thank you.
Terrific. Any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on document 11?
This is Chris Sykes. We do not have anybody signed up for testimony on document 11.
Wonderful. Then I will accept a motion for initial approval of document 11.
This is Amanda. I can take that motion.
Please do.
Amanda Jashinsky, I move the initial approval of document 11 MSB 25-09-17-C revision to the medical assistance nursing facility reimbursement rule concerning HBU updated criteria section 8.470 incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, ma'am. May I have a second?
This is David. I second.
Thank you, Mr. Pump. All in favor, please say aye.
Aye.
Aye. All opposed? Abstentions? Very good. Document 11 passes initial approval. All right, kids, hold on to your hats. We are on to emergency rule document A. And we have with us to get this party started, Miss Bonnie Silva. Good morning, Bonnie.
Morning, Madam Chair, members of the board. Once again, Bonnie Silva, and I have the honor of serving as the Director of the Office of Community Living. Online today, I do have Candace Bailey to serve as a phone a friend in the event that I can't answer some of the questions you might put before me. Today, I will be presenting emergency rule titled Medical Assistance Rule Concerning Medicaid Sustainability Initiative Changes, Community First Choice and Community Connector MSB 25-11-06-B. If we can move to the next slide, please. Want to start our presentation with gratitude. I want to thank the stakeholders for all of the thoughtful feedback that they have provided through our ongoing engagement, through the testimony that they've provided both in writing and to the board. I want you to hear that we have read every single word. We are not looking to be right in our implementation. We are looking for what we are missing and what we need to consider as we look to implement some of the most challenging regulations and changes before us. So thank you. Thank you to the board for hanging in there as we did our preview last month. That was many, many hours. And while this is going to probably continue to be difficult, we appreciate, I think, the ongoing engagement and collaboration as we figure out a path forward, hopefully a sustainable path forward for our disability community here in Colorado. Next slide, please. So today I'm covering several changes in one. So we are looking to update the unit limitations for the community connector benefit. We are also looking at age-appropriate authorization for that same benefit. I will be presenting soft caps for personal care, homemaker, and health maintenance activities, and also the reduction in the cap on the weekly homemaker hours that a legally responsible person can provide from 10 hours to 5 hours per week. I have some other things that we have done within this regulation to really bolster the rule to ensure that we have clarity for both our stakeholders and consistent implementation by our case managers based off the feedback that we've received. I want to note that this rule no longer includes the 56-hour caregiver per member limit or the IRSS rate alignment. Those are actions that were tabled by the JBC for later consideration. So the items before you that were in front of our joint budget committee, they have voted to move forward with. And so therefore, we are bringing them forth to the Medical Services Board. If we can go to the next slide, please. I want to start, I know Rachel gave an overview of why we're doing emergency rules versus regular rules. And I just want to acknowledge, like, it sometimes feels like we're in the upside down. This is not typical policy making, and we don't like emergency rules, I think, any more than the board does. But given the fiscal crisis that has faced our state, our governor instituted an executive order directing the department to move forward with the implementation of several reductions. So that was our state authority. So to meet the requirements in the executive order, we really have to bring these rules forward via an emergency rule. It's important to note that services are not authorized the day that people need them. They're typically authorized in a planning meeting that occurs anywhere from 60 to 90 days in advance of when those services will be active. So to operationalize this, I mean, huge shout out to my extraordinary team. They have been working near around the clock since October to engage with stakeholders, to craft training, to make sure that our case managers had what they needed to, starting in January, again, via the executive order. I know it feels out of order, but this is sort of the world that we're in, that they had the training they need to go ahead and engage in those conversations with members and families. If we didn't do emergency rule, we would have had to bring this rule before you October 1st. And of course, the executive order wasn't live until October 31st. And so this is just the timeline we're in. I want to highlight, if we can move to the next slide, please, that sometimes I think the perception is that emergency rule means we're not working with the community, and the community voice in the implementation of these reductions is essential. And so we have engaged with hundreds of stakeholders on the rules that are before you today. The slide says we had feedback of 49 stakeholders. We've made 49 changes based off the feedback from hundreds of stakeholders to, again, make sure that even though this is extraordinarily challenging, we want to make sure we're doing our best to incorporate that feedback and get it as right. I think the great thing about the emergency rule process is it's not final. So even I think yesterday I got 80 comments in my inbox and ongoing, right? We are not stopping our listening. We want to make sure that between, the rules that get approved today and the final reading, which is 4 months from now, we will continue to engage with our communities and make sure that we're doing any necessary refinements to get it right. But based off the feedback that we have heard to date, we have added details around the exception process. What does that mean, really? So typically, we don't put a ton of details around exceptions process and rule. It's an operational procedure. We're always trying to thread that needle. But we've heard from stakeholders that they want more detail. They want to make sure that it's being applied consistently. So those are some of the changes that we have made and are willing to continue to further evaluate. We have defined the age-appropriate task standards and task standards for adults. That is a final rule that we went back and provided some additional clarity on, again, based off feedback. And then we modified our language specifically around the community connector benefit to further clarify how and when that service could be authorized and used, again, based off feedback. So I want you all to hear that this is not a one and done. We are very committed to listening to our communities, to hearing from them. And while these are extraordinarily challenging changes, we want to, maybe I'll channel myself, make the best worst decision we can as we're looking towards long-term sustainability. If we can go to the next slide, please. So first, I am going to talk through section 8.7514, and this is to give you some framing around our changes to the community connector benefit specifically, and to outline the changes that we have made. If we can move to the next slide, please. So I think there's a lot of misconception around what community connector is. So it is a one-on-one support for a child or youth to build skills and relationships needed to participate in community life using real community activities as the learning environment to do that. It has to have measurable goals. It is a 1915C waiver service, both in our Children's Extensive Support Waiver and our Children's Habilitation Residential Program. So those are children's programs that are targeted towards children and youth with intellectual and developmental disabilities. From a provider perspective, the person rendering the service must be over the age of 18, meet our state required training, follow the service plan, document the services, and make sure that they are sort of implementing that service in alignment with our policy. Parents serving as providers must focus on this definition and not routine parental care. And so you'll see in the coming slides that this is something that we've been working to disentangle to make sure that we're leveraging this service as intended. If we can move to the next slide, please. So we always look at what our colleagues around the nation are doing. Well, I mentioned in our previous presentation that Colorado is one of the top performing states for long-term services and support, something our community should be really proud of. We always want to steal from the brilliance of others wherever possible. And so for this service, it is really unique. We only have 3 other states in the nation that offer a service like this, and only one other state that is allows legally responsible persons to render that service. When they do it, they also require an assessed exceptional need to access the service. So some of the changes that you will have before you are really aimed at making sure that we have some alignment with what our colleagues are also doing, making sure that we have reasonableness around how we are authorizing and leveraging our benefits. If we can go to the next slide, please. So this just gives you some information around how this service has grown and why it has grown. So the first line shows the growth in the average monthly participants, or the numbers of members that are accessing a particular service. As you can see, the use of this service has grown significantly, 510%. I want to draw your attention to some policy changes that were made at the federal level that in part sort of have driven this increase here at the state level. So when the COVID-19 pandemic happened, we made massive changes to how services could be delivered here in Colorado. And services that previously could not be rendered by legally responsible persons, we worked with our federal partners to say, please, let's mitigate the number of people coming into people's home. We want to make sure services continue. We want to mitigate the risk to a high-risk population. And so got approval to do that. Following the end of the public health emergency, CMS changed longstanding guidance around how and when legally responsible people could render services and said, states, you know what, you can continue to allow this. We wanted to be responsive to that federal change and figure out how in Colorado we could also continue to allow that. So we initially implemented it with a cap, thinking, great, we're going to be proactive, we're going to put a cap in place, and we continue to see the services increase in a way that we didn't expect. So we provided training to case managers on age appropriate sort of use of this service and how the service should be leveraged. And then eventually we put an overarching cap that wasn't specific to legally responsible people in place. And even with all of those actions and monitoring, the utilization for this service, the cost for this service has continued to increase at a rate that is quite frankly unpredictable and more directly that the state can't afford. So you can see the paid amount in particular is pretty astonishing. We're at $67 million annually for this service, just in a very short period of time. So we have dug deep to really try to understand what is driving that and will these changes successfully mitigate what we are seeing. So if we go to the next slides, please, we really dug deep on why the service was being authorized at such an incredibly high rate. We saw that so a federal requirement is that every service in that plan is based off assessed need. So you shouldn't see identical plans across the board. Certainly, because people with disabilities may have similar needs, you're going to see similar sort of authorization, but you should be able to back it up to say this person has this need based off of our assessment. We saw that it was being added, quite frankly, as a default service for just about anybody who was in that waiver, which I have to tell you, when we look at service plan, I mean, it's unheard of to have a singular service so widely used across the waiver program. We also saw that it was being authorized for entertainment services. So things like going to restaurants, going to movies, again, not aimed at the how do we have people in the community, for example, maybe being a trail steward at a local hiking trail, or working in a library, or a Boy Scouts sort of event or activity. Like, how are we helping that child or youth build the skills necessary to actually build and engage in their community? We also saw that it was being used simply for supervision, like the child needed extra support with supervision, and so the service was being authorized. We saw that it was being utilized in group settings. So, the paid staff also had other children there present when the service was being delivered. And again, it is designed to be a one-on-one skill building activity. And we often saw that the service was being authorized instead of more appropriate services. So for example, if a child or a youth had significant behavioral concerns in the community, instead of looking at what behavioral services might look like, or additional personal care services might look like, that the community connector was being authorized in lieu of that. The other challenging thing that we saw is, even though we tried to put these caps in place, again, as proactively, that services often were being authorized up to the maximum across all plans rather than based off of assessed need. And then we saw it being authorized for things that would be typical parental responsibility rather than really what was required within the actual definition. And that it can't supplant what is school-based community integration and enrichment activities. So we saw a need, a responsibility at a state to make sure that in addition to the changes that are before you, that we provided training, that we provided further clarification, really making sure case managers had all the tools that they needed to ensure that this service was leveraged appropriately. I want to be clear, we think this is an incredibly valuable service. We don't want to get rid of it. We also think, and I've gotten pushback both ways in terms of the allowance of legally responsible people to continue to provide the service. There's value there too. And, there's some pushback saying you should have stopped that allowance and kept the caps in where they were and let the service be leveraged in different ways. And so, again, we are taking extraordinary challenging sort of situations before us and figuring out how we can best serve the community as a whole. But some real examples of where the service has been leveraged in a way that is truly outliers is, a 3-year-old requesting 20 hours a week of Community Connector to build their social skills. Parents are responsible for building social skills for every single 3-year-old, right? A 7-year-old requesting 30 hours a week. Again, at 30 hours a week of engaging in your community is really, really significant to help that child with increasing their physical activity. Again, that's very important, but not the purpose of this service. Or a 16-year-old requesting 22 hours to support with sort of screen addiction and removing from that, but with no clear plan on what that community engagement would be. So again, we took responsibility in looking at how we could better leverage this essential service. If we can go to the next slide, please. So in the exclusion sections, we've included language around the unit cap and the exceptions process to ensure that appropriate utilization of the service and its consistent implementation across case management agencies. We've made the following changes. Bless you. We've created and implemented a definition for what is a parent or legal guardian responsibility. I think that, I have thousands of case managers across the state, and many of whom have never been parents themselves. And so it's not intuitive what would be, especially when you're working with people with incredibly complex needs, what would be a Medicaid cover service and what would be a parental responsibility. We updated the definition to make sure it was really clear, the scope and purpose. And then we added clarifying language in terms of the inclusions and exclusions in sections, again, trying to proactively better ensure that this service is authorized appropriately. If we can go to the next slide, I'd like to move into the presentation on the implementation of our soft caps for certain home and community-based services. Here you will see changes to sections 8.7515, 8.7523, 8.7527, 8.7528, and 8.7538. If we can go to the next slide. So the benefits that we're talking about today are provided by traditional agencies, and then they're provided under 2 self-directed options. The first one is in-home support services, or IHSS. The other one is consumer-directed attendance support services, or CDOS. And so the soft caps I'm talking about will be applicable across all those service delivery models. What we didn't want to do is target one service delivery model and then we disproportionately drive people to another. So we're looking at being fair and consistent in how we're applying these. They apply to personal care, so that's non-skilled support with somebody's activities of daily living, homemaker services, and then what is called health maintenance activities. And health maintenance activities in a self-directed model are skilled care activities. It's a blend of what would be considered RN or CNA level care. In these self-directed models, you can hire non-licensed or credentialed staff because we have portions of the Nurse Practice Act waived to render that care. If we can go to the next slide, please. Similar to Community Connector, so why are we making these strategic targeted changes? And this is because this is an area of growth for us. So you can see that we've had a 154% increase in the number of people accessing this service delivery model. Similar to Community Connector, year over year, we're seeing the trend go up, and we are doing training, and we are implementing new standards, and we just haven't been able to stymie it in a way that is predictable for our state budget. The cost per member notably is going up to 84%, but the paid amount is significant at 367% in terms of the cost driver for our office. And again, part of that is intentional. We put massive increases into rates to make sure that we have a workforce to provide this care. And you can see utilization is also growing up. If we go to the next slide, please, I just want to give you a similar view of consumer-directed support services. I think it's important to note CDOS is the one agency where there's no provider involved, right? So that member is directing all of their own care. And so the growth here is not as significant because the incentive here is not as significant. And so one of the things that we're trying to do is make sure that between providers, case management, members, families, that we just have those proactive guardrails in place. But similarly, we've had an 82% growth in that paid amount. And as we're implementing these soft caps, we don't want to drive people to one area or another. If we go to the next and last slide, just in terms of cost growth, we have our non-consumer directed personal care and homemaker. So this is through an agency. But you can see that we had a negative 4% growth in the average number of participants. And that reflects just how attractive these self-directed models are in terms of people getting their care needs met and how easy the migration goes there. But we still have significant triple-digit, double-digit increases in what we're paying and the utilization of these services. So it's important that we look at a comprehensive approach as we're looking at soft caps. If we can move to the next slide, please. So the soft caps here that are proposed in regulation, represents 18 hours a day. And we don't expect, again, everybody to be authorized up to that cap. And we want to make sure that we have exceptions processes in place for those that truly need more than 18 hours a day. You can look at, right now, based off of how services are authorized, what is the percentage of people that will be impacted? So 6% of the people utilizing personal care, 10% of homemaker, and 7% of health maintenance activities. It's also essential to highlight that our estimates around cost savings for these soft caps were incredibly conservative. The goal here isn't to stop people from getting the care that they need, but to have a process in place for truly outlier trends, for us to evaluate that both at our case management agency level and at the state level to ensure that service authorization is appropriate. If we can go to the next slide, please. So rule changes to implement these soft caps, we have included that for personal care, homemaker, health maintenance activities, CDOS and IHSS, and we have updated based off feedback and will continue to hear feedback, the exceptions process to exceed the cap in our choice section. If we can go to the next slide, please. The next section that we're bringing forth that the JBC voted to move forward is looking at how we could look at our allowance around legally responsible persons for homemaker in particular. And again, looking at how we could bring that more in alignment with what would be considered acceptable nationally here in Colorado. So before the rule, legally responsible person could get paid up to 10 hours a week of homemaker. We're reducing that in half by 5. If we can go to the next slide, I think that it's important to know that we're not reducing the amount of hours that a member can receive. So if they truly need more than what the legally responsible person can provide, they can have that authorized. There's no prohibition there, but it is around making sure that our allowance around legally responsible people, all states have caps around what paid family caregivers can get paid, is more in alignment with what we would see to be typical. You can see that similar to what the story on Community Connector, where I talked about public health emergency, we previously didn't allow legally responsible people to render this service. We changed that allowance, we kept it. And so we saw these steady double-digit increases year over year even with the cap in place. And so we're hopeful that this will help, again, lend towards a sustainable long-term system. We go to the next slide, please. The rule changes for the legally responsible person for homemaker hours. We updated the annual limits for reimbursement. So again, from 10 hours to 5 hours, or it's 520 units to 600 and 220 units. We updated the definition of legally responsible person to further clarify some of the most, I think, frequent questions we got is, for an adult, is a guardian considered a legally responsible person? The answer is no. There's no legal responsibility for you to provide care post 18, and so they would not qualify. So what we're talking about here is typically parents or legal guardians for folks under the age of 18 or spouses. That is who's included in this bucket. We also clarified that a member can only have 2 legally responsible persons that are paid. So they might have more than that in their life, but we will only authorize up to 2. We've conversely heard feedback that this is unfair to single parents. So in a 2-parent household, you might have mom and dad both getting that 5 hours a week. And so it disproportionately impacts them. I hear that, I see that. I think this is one step in the right direction. I don't know that it's the only step in the right direction. We are trying to mitigate, again, impacts across the board. If we go to the next slide, please, I will cover sort of the other changes that were made to align the regulation with current practice to improve enforceability and consistency upon our existing expectations. And something that has become abundantly clear through general stakeholder feedback is the lack of clarity within our regulations for these services is causing challenges. So to the extent that we heard that feedback, we went in there and took that feedback and updated. So if we go to the next slide, first we included definitions for age-appropriate task standards for children and task standards for adults. These were rules that were adopted, approved January 9th. We were asked to go back in and provide further clarity, so we did that. The Direct Care Service Tool Calculator, it's a tool that case managers use during service planning to determine these task standards for children and adults. I want to say that the revision did not identify which services these tools should be applied to, nor did it specify that additional hours may not be authorized beyond the age-appropriate task standards. We've heard that during feedback. So these are just parameters. They're guidelines for saying what would be typical, and then you need to do the assessment, work with the person to understand what should be actually authorized. Next up, we clarified some definitions. So if we move to the next slide, please. There are 2 other definitions that tie directly to the authorization of personal care, homemaker, and health maintenance activities that we're including in this revision. First is simply relocating the existing definition of extraordinary care. Right now within our regs, it only sits under CDOS and it applies to all the services. So we just moved that definition and made it clear that the definition of what would be considered extraordinary care, therefore we could pay for it by a legally responsible person, applies to all of these services. Additionally, the parent or legal guardian responsibility that was mentioned in the community connector also applies to the authorization of personal care, homemaker, and HNA. So again, trying to be consistent in how we're implementing these. And then last, but certainly not least, if we go to the next slide, we removed nurse assessor and skilled care acuity language from our rule. We launched a nurse assessor program in August of this year, really aimed at actually being supportive to members and families, helping them understand all of the skilled care needs that they have for. That did not happen. There were so many operational challenges with that program. So on December 22nd, we pulled the plug. We said, this is not helpful. We are not moving forward with this. So we are removing this program from our rule language as it is no longer in existence. And next slide. So here's where I'm going to pause for questions from the board. I just would like to thank you for hearing these rules today. The set of rules include changes that I understand are incredibly difficult to make, but really are aimed at being measured and strategic, aimed at looking at where our trend is an outlier while preserving access to these services and eligibility categories for these services for the long term. I welcome questions from the board or anyone who has signed up for public comment.
Thank you so much, Bonnie. Last time I started with the peanut gallery, so this time I'm going to start in the conference room. Are there any questions from the board in the conference room?
I just have, Madam Chair, this is Cassie Littler. I just have a suggestion. I wonder if we could talk about each one individually so that we're not jumping around. So like talk about community connector first. Would that be okay with the board?
I guess I don't understand your question. I'm sorry.
So there was a lot of information covered in different programs within this emergency rule. And so I'm wondering if instead of talking about community connector and then jumping to something that was in the end of the presentation, just to keep my brain in line, if we could talk about one of the topics at a time.
Ms. Silva?
Thank you, Madam Chair. Absolutely. I think that's a great suggestion. Thank you.
All right. All righty. Anybody else in the conference room?
I had an actual question as well. This is Cassie Littler.
Please go ahead.
Okay, when discussing the community connector program, I wondered in the slide 9, you had referenced that the LRPs began to provide service in fiscal year 2021, and that there was initially a cap. I wondered if you could point out to us when the cap was removed in years after.
Thank you. Yeah, okay, I'm making sure I can jump in. It's been a long time since I presented a rule. So the cap was never—
We're glad to see you and would like you to present more. Our most seasoned members of HCPF gives us the very best information. Go ahead, Ms. Silva.
I think you've heard from many members of my team today, and that's not true. So the cap was never removed. Okay. So my intention here is to say we have taken measured incremental approaches aimed at addressing this trend and have been largely unsuccessful. And so while the changes before you may feel dramatic, they are after a lot of effort on the part of my team to rein in the expenditures of this service to ensure that they're appropriate and in alignment with sort of the intention of the policy.
Thank you.
Anyone else in the conference room?
This is Dr. Amanda Jashinsky. I have a comment question.
Please do.
So I really appreciate, Ms. Silva, that presentation. I think it was extremely helpful today. To me, it seems I've made a couple of thoughts after this. One is, first and foremost, I want to emphasize what you said, that this is going to need multiple revisions, because this is undoubtedly going to have a lot of impact. And I think we all hope that the state and HCPF will continue to look at what those impacts are, what revisions can be made to ensure that the clients, and folks on Medicare are continuing to get the services that they need, and the care they need. So I just wanted to emphasize that, because that would be my sincere hope as well. I also wanted to kind of ask whether this is an appropriate summation of what you presented. It looks to me like when the rule was initially written with a community connector services, there just wasn't enough definition in there to really ensure that those services were used the way HCPF had initially intended. So when I look at your revised language, it's really to make it more in line with the definition that you presented at the beginning of the presentation. Would you say that's correct?
Yes, thank you. We started with training, right? So we did extensive training with case managers to say, look, we're looking at how this is being authorized. And then we landed on additional training plus a rule revision to really drive home where we saw inappropriate authorization and where a clarified rule would better mitigate that proactively from happening.
Okay. And then I think the last thing I would just like to understand more, sorry, this is Dr. Mandrushinsky again. The second thing that I would like to understand more from Ms. Silva and her team is many of the folks who wrote or provided testimony, to me, based on what they're describing, would probably qualify potentially for additional care above the caps. And I guess I was wondering, how do you feel about the process in place for this case review that will need to take place? Like, how do you feel this will come about? Because I guess my concern is that you're going to get a flood of ballot requests. And do we have the infrastructure in place to process all of those requests?
That's a great question. I would say, like, go back to a flood of reviews. This is Bonnie Silva, by the way. I think I need to say that every time. We already have an exceptions process in place. So this isn't new as part of this rule revision. So this is something case managers are familiar with. This is something that my staff are familiar with. And I would say that based off of our review for how this service is being authorized, we feel like the number of people that are going to be approved above this cap or for an exceptions process likely won't be huge. But we want to make sure we have that safety net in place and the review capacity to truly look at that and make sure that when it is appropriate, that it is authorized. And so we do have the infrastructure in place. I also want to say the other thing that we saw is that it wasn't that there was a need, it was that the community connector was the inappropriate service to meet that need. So there will also be a dialogue around why isn't this person being offered X, Y, and Z service that they're clearly eligible for and need based off of what you're submitting. So it allows for more real-time engagement there as well.
Wonderful. Thank you.
Anyone else in the room?
Madam Chair, James McLaughlin.
Go ahead, James.
Yeah, I think like the rest of the group, I've put a lot of intentional thought into this over the several months and certainly over the last month, and had many sleepless hours over it. Because I see these services utilized in our community and I see the impact they have on the people within our community. And I also don't want them to go away. And what I'm hearing, and I want to make sure what I'm hearing is correct. What I'm hearing is if we don't take action to stem the flow of increase that's occurring within these programs, we're going to see even greater cuts and even more people are going to be profoundly impacted up to and including the point where some of these services could potentially be lost completely. Am I misunderstanding that?
Thank you for the question. You are not misunderstanding that. Like when I read the public comments, when I listen to the testimony, I hear people fighting and I hear them afraid. Saying, look, I have my life figured out and please don't make these changes. I want you to hear, we are also fighting to make sure that we are mitigating significant, impactful harm that will inevitably come if we continue to let the trend in these services grow at the rate that they are. I also think what's important to hear is this increase in expenditure is not the family's fault, right? Like they're not the ones authorizing the services. They're not the ones deciding what's appropriate. And so it is a comprehensive approach to say, the reason we're focused on Community Connector in particular is I can tell you without a doubt it's being authorized in a way that it shouldn't be. That's again, not the family's fault, but we need to make these regulatory changes. We need to put these caps in place so that we can preserve this service ongoing and preserve the ability for legally responsible people to provide it. If we don't do that, to create a balanced budget, I will be asked to come back with significantly deeper and more impactful reductions. That is 100% true.
Thank you. Madam Chair, can I ask a follow-up question?
Floor is yours till you give it back, James.
Thank you. And that, I'm glad you said that because that was my second question. My understanding, and I know significantly more about these services, this program now than I ever have, probably a microcosm of what many of the folks here in the room understand about it, and they have lived experiences associated with it. So I really look forward to hearing their input as well. But the term I've heard you say 3 times now is the gatekeepers, that the case managers are the gatekeepers for these services. They're the ones that determine whether or not somebody qualifies for these services based on criteria. And it sounds like maybe, and I'm not trying to assign blame, I'm just trying to understand this, that maybe maybe they didn't quite do things the way they were supposed to. And that there was an attempt made to educate and to clarify, and that wasn't successful. So then that takes me to the next thought in my mind, which is accountability. What does that accountability piece look like for these case managers? Is that addressed? Because I didn't see that addressed in the rule at all. Maybe I missed it. But
It's a great question, and one with a bit of a complicated answer. So what we're seeing, how we're seeing things shift in the community, there's a couple of causes, right? So it's certainly case managers have an essential role, right? And they have a impossible role, if we're being honest, right? Their job is to develop a rapport and a relationship, advocate, and also say, no, you don't get what you're asking for, and yes, you do, based off of assessed need. We have also seen in the last few years in particular, providers coming in based off the richness of these benefits, doing direct to consumer advertising, coaching people on the eligibility process, coaching them. So the case manager only knows what's before them. So we have strategies in place aimed at addressing that. You know, organizations saying, let me tell you how to make a lot of money through Medicaid. Families come and work through me. That is a challenge before us that has nothing to do with the case managers, and it is an extraordinary challenge for them as well. We are trying to address that as well. That there's no rules before you today on that, but eventually there will be. And so, you know, we took a softer-handed approach initially. When that didn't work, you could see our approach has become more rigid. And so before you, we believe these are the actions that need to be taken to truly better ensure we have a responsibility as a state. Let's clean up our definitions. Let's make sure our regulations are more explicit. I mean, the number one challenge for my office is we serve people with such unique needs. We can't have regulations that are so rigid that then there's not enough nimbleness for them to work within them, but so broad that, you know, you can drive a truck through them. So you see us as a state trying to better thread that needle to empower those case managers and doing their impossible job, which is making sure that they're authorizing in alignment with our policies as they're written. So we're also trying to do that. There's absolutely ongoing accountability from a case management perspective. We're doing reviews of what they're authorizing. We're doing ongoing training. We will and have put them on corrective action plans if they are not doing the job that we have asked them to do. So there's an entirely separate accountability stream there, but I also want to be really thoughtful about saying this must be the case manager's fault, because there is a lot of intersecting issues that led us to where we are today and the actions that must sort of move forward.
I appreciate that. Thank you very much.
That was Bonnie Silva speaking once again. Did that get everything you needed, Mr. McLaughlin?
It did, Madam Chair. It sounds like they are triaging things to the best of their ability. So thank you.
Appreciate you, Mr. McLaughlin. Do we have any other questions in the conference room?
Madam Chair, this is Cassie Littler. I have a follow-up question to that.
Go ahead.
I was wondering what we could learn from the nurse assessor program. Is there any, takeaways from that program that we could apply to what we need from the case management agencies, right? And also, in addition to that, how can we help bolster the case management agencies to be able to take on this tremendous amount of work that is coming their way and is already on their plates? Is there, ideas or rules or things that are going to be coming to help with those needs?
Great questions. This is Bonnie Silva. I'm getting better, Madam Chair. For 10 tries. So in terms of the nurse assessor, so many lessons learned. Again, the nurse assessor was not a cost savings strategy. It really was aimed at when we turned back on the prior authorizations for private duty nursing. We saw that often agencies would only request what they were willing to provide. And so a family might get a denial and not understand that while their nursing hours were reduced, they were also eligible for CNA hours. But because the agency didn't provide CNA hours, they didn't have this comprehensive view of all the services for which they might be eligible. And it's important to note our case management agencies don't actively manage the private duty nursing long-term home health side of the shop. At the same time, we're implementing community first choice, where people have the opportunity to self-direct a lot of that skilled care. And so we wanted to have this like single non-biased point where you could say, here's what this might look like for you. I think one important lesson was, when looking at what vendors promise you and what they're actually able to pull off, long-term care is a really complex area of policy. And so for them to be able to have the expertise to really speak to the non-clinical side of it was just too big of a mountain for them to get over in a way that could effectively serve our communities and be appropriately staffed. So I could probably talk about the nurse assessor for a full hour, but I think at the end of the day, we heard from our communities, this is not helpful, and we listened and acted very quickly as we could, to just dismantle the program and say, let's focus our energy in other areas. From the case manager perspective, again, this is why these emergency rules are so important, is that training is essential on the front end to make sure they have the tools and resources to actually implement these changes. We also host ongoing office hours for them. So as they're implementing these changes, to understand what questions do they have, what's going well, what's not going well. I think that is essential. I also think the passage of these regulations is important. Like having a regulation to point to say, you know what, I know this previously happened, but there's these new parameters in place. And so we need to work together to sort of come into alignment with this, revised definition for example. The more clarity and tools we can give them on the front end, the better the authorization is going to be on the back end.
Does that get you in the conference room?
Yes, thank you.
Wonderful. Dr. Martin, I saw your hand first.
Thanks. This is Barry Martin. I have, I think, 4 questions, and I hope we're not taking up too much time away from the community people who want to present, but I think it's important to get these things out. For Bonnie Silva, we saw that, a large part of this is due to the 500% increase in the number of participants. We also had a significant increase, I think 100% increase in the per member per month cost. And I think I know what drives that, but I'm curious to hear what you think about what is, we're not only having a lot more enrollees, but each enrollee is getting a whole lot more services.
Thank you, Dr. Martin, for the question. I think that when we look at our data, we can see that when we allowed for the service to be rendered by legally responsible persons ongoing, we saw the increase significantly go up, both in the number of people wanting the service and also the paid amount. The other thing that I don't think I talked about as directly was that this was a highly reimbursed service. So on top of that, we were able to determine that our reimbursement for this service was really out of alignment with what we would typically pay for other similar services, which is why we've done the rate reduction to sort of correspond with it. So from a provider perspective, it was really attractive, right? It's a highly reimbursed service. You have a built-in workforce who's willing to work the hours that you'll authorize. And so we saw it skyrocket. Unfortunately, we saw it skyrocket in a way that really wasn't in alignment with how the service was intended to be used.
Thanks. This is Barry Martin again. So just to follow up on that, if I can, Madam Chair.
Absolutely. And I just wanted to confirm once again that that was Bonnie Silva speaking. Go ahead.
So for each individual member, the per member per month cost is not only that they're getting more, each member is getting more services, but we're paying more for those services. Is that accurate?
This is Bonnie Silva. Thank you, Dr. Martin. Yes, so what we're seeing is that this service is being authorized to the cap pretty consistently, and that it's being utilized to the cap pretty consistently. And so we are seeing that across the board.
Madam Chair, can I ask my second
You've
question?
got the floor, Dr. Martin, until you give it back to me.
Thanks so much. This is Barry Martin. Another question I had, and I think some of the written correspondence mentioned this as well, is that when you look at the age-appropriate task standards for recipients, I can imagine that, say, the general supervision of a 4-year-old, making sure they don't walk out the house or fall down the stairs or those kinds of things, for a child without disabilities could be fairly minor. You could be doing other things and kind of keeping an eye on the child who's in the same room, as opposed to a person with significant autism, say, for example, who needs constant one-on-one, right there, right now supervision. So I'm wondering, for some of those things that, like, what do you expect from a parent or any child versus what do you expect for the parent of this child? It seems like some of those caretaker kinds of things, even like giving a bath, could be so much more difficult for a person who's having self-injurious behavior, and screaming and everything could be a much different thing than giving a bath to a 4-year-old who doesn't have those conditions. So I'm wondering, how does that work in this system?
This is Bonnie Silva. Thank you, Dr. Martin. I'm thankful you asked the question because I don't think that I hit on that during the presentation with any level of depth. So the task standards that we use are based off published data, and they are for typically developing children. And it's how that works. And what they're intended to be in terms of the training is a barometer for case managers to use to understand, okay, what would this look like for a typically developing child or adult, right? Like, what would the need be? And then how do I apply that to the assessment of need, sort of what it is that's being reported, what it is that I can assess to figure out how to authorize the service. So that's how those are intended to be used. I hope that's helpful.
I think so. I'm sure we'll hear a lot more testimony about this issue. My next one is on the soft unit cap for services. When we look at the table, it looks kind of encouraging that if you say that, well, a lot of the changes in these services will affect a fairly small number or percentage of patients, 6% of patients or 7%, that sort of thing. But in regards to my, or relating to my question that I asked at the beginning of today, that 7% of people are the people who really need these services. And then the other kind of caveat to that question, perhaps, is that, you mentioned before that we're going to allow exceptions for these. And I'm wondering, so if we're going to allow exceptions, then are we really going to save the money that we're hoping to save? Or are we just making it a bigger hassle to get the services?
This is Bonnie Silva. Thank you, Dr. Martin. So again, I'm going to reiterate a point I think I said in the initial presentation is our fiscal estimates around these changes are intentionally very conservative. The idea is that not everybody above those hours would have a service reduction. We 100% understand that and expect that and think that that is appropriate. What we need to have is the proper sort of processes in place to ensure that that is the case. The goal here is not to reduce services that are truly necessary. The goal here is to make sure that we're actively reviewing people that are above what would be considered typical to ensure that that is appropriate. So I hope that helps answer your question.
It does quite a bit. Thanks. And that's the end of my questions for now, Madam Chair.
Appreciate you, Dr. Martin. Dr. Kennard, you're up.
Thank you, Dr. Kennard here. I should preface this by saying I'm pretty sure, like all of my fellow board members, I reviewed all 42 of the written submissions in detail and heard them. And I really am very thankful to the people that took the time to write down their thoughts and send them our way. That was extremely helpful. And part of what I'm going to ask and say, Bonnie, is really trying to consolidate some of their key issues and put them in front of you now so that hopefully you can address them now and perhaps decrease the burden that people might feel to present later on. First is reassurance about the exception process that, as other people have said, do we have the bandwidth to aggressively get after that? Because there are clearly cases that are devastatingly needy exceptions. The other issues that come up several times, as Dr. Martin said, is age-based criteria. And there were certainly convincing stories. I heard you, writers, of where one 5-year-old is not the other 5-year-old, and that making those distinctions is sometimes not helpful. So again, just reassurance that that won't be a barrier to people getting what they need. The third thing, and you did mention it, was the single mom. I'm pretty sympathetic to that. That sort of doesn't make sense to me, that a single mom, when it seems to be a single mom 99% of the time, couldn't be paid. There's 10 hours of work that needs to be done, and we'll pay for it if there's two parents around, but not if there's one parent around. I think you may want to speak to that, and again, because I know there are single moms waiting to comment right now. Next is the rural aspect. I don't know the answer to this, but clearly, well, at least it's not a representative sample, but of the letters that we got, many of them were from people outside of sizable metro areas and that therefore away from more, be it family or professional support. Do we have any way of accounting for that? Because that's just a really challenging situation to be in. So those are kind of exception process, age-based, single mom, rural. And then I'll go back to Dr. Littler's request. I kind of wish that this had been presented in two chunks, the community connection and the CFC, home care provider provision changes, because they seem to me to be, although very related, separate. It would have been nice to split them. I think we could have had might have easier decisions to make if that was the case, but if that's too late, that's okay. So did you hear my questions in there, or do I them again after that ramble?
I did. This is Bonnie Silva. Thank you, Dr. Kennard, for your questions. I'm going to do my best to be responsive to them. So in terms of reassurance on the exceptions process, our goal is to make sure that people have access to the services that they need and also to create a system that is sustainable. Exceptions processes are not new for my office. This is a proven process that we have in place. They're not new for case managers. And I will also say, I will reiterate my comments, I think at the beginning, that these are emergency rules. And the great thing about emergency rules is we have 4 months to continue to work through implementation, to continue to receive feedback before final adoption. So our intention isn't to be rigid and our way or the highway. Our intention is to make sure that we are incorporating feedback, that we're understanding where we need to bend so we don't break, and that we truly sort of have the infrastructure and the safety net process in place to catch people where we need to. Now, I also want to be honest, like we are reducing the richness of this benefit very intentionally on the community connector side. And so also paired with that, making sure that we are directly working with case management agencies to ensure that people understand the full scope of benefits for which they might be eligible. And so if it's not this, what else might it be? From a soft cap perspective, again, the goal here is to make sure people have access to the services that they need. And you know, that if somebody demonstrates an exceptional need for that high utilization of services, that we have a process in place to support that. That is our goal, but also to make sure that we are being more proactive to ensure that that is in fact the case. So both things have to be true for us. In terms of the age-based criteria, it is because that is such an issue that we are seeing when we're reviewing how services are being authorized, what is the justification behind them. This is an area of significant struggle for our case management agencies to really disentangle what is typical parental responsibility versus what is a Medicaid paid covered service. So it is essential that we really lean in here. So we are going to have to look at services that have been previously authorized and make sure that they are removed from authorization, while also making sure that family understands what else might they be eligible for. If that's a parental responsibility, how are we wrapping a service package around that family to best support them? Is Medicaid perfect? Can we be the answer to everything? No, we can't, but we can certainly try. I want to say case managers have the ability to work through that age-based criteria within their own empowerment and their own authority, and also working with, you know, their supervisors. So we have it at multiple layers. The single mom, like that is, as a single mom, that is incredibly, like I really truly feel that. I have to maybe put out an unpopular response in that I have to look at what is the right policy for the person, not the right policy necessarily for the family, right? So looking at you know, is it appropriate to bringing our allowance in a, you know, to 5 hours a week for homemaker as a, for example, that's where it's a legally responsible person, we could pay for 5 hours a week. I'm not sure that's the right answer. I do know that out the gate, we can look at nationally, that's sort of how that service is authorized. Maybe it's that we reduce it even further and we say within a single household, only one legally responsible person can get paid up to 5 hours a week, so that we're not disproportionately impacting single moms in that way. I mean, that is another avenue that we can move forward with. Sometimes we have to take steps, and this is like step one, and really looking at, you know, what would be step 2, 3, 4 down the road. So I don't think that's the most eloquent or easy answer, but that is sort of the initial framing that we're looking at when making these incredibly difficult decisions. From the rural aspect, we do have a rural sort of task force aimed at looking at how we can ensure we have provider capacity in more rural areas. We also have a direct care workforce aimed at bolstering this workforce statewide, the rural areas of our state. We understand that there's unique needs in our rural communities, and those are, I think, needs that we are very responsive to. And looking at how we can make sure, I think consumer direction is a very big opportunity for those communities that help support, bring in providers in ways that we haven't been able to do historically. Is it a perfect answer? Absolutely not. Do we still have more work to do? Heads down, and we are on it. But we are looking at our rural communities and saying, how can we put your arms around you? And thank you for the feedback on the 2 chunks. I am very regretful that I didn't pause after presenting Community Connector, take questions, and then move forward. I was trying to be responsive to the time that you all have allotted for this important work and make sure that I could hear questions from you and from the community on these changes. But going forward, that feedback will be incorporated into how we present.
That got you, Dr. Kennard?
Dr. Kennard, yes, thank you. Thank you, Bonnie, for trying to address those.
All righty, I don't see any other hands in the Zoom gallery. Are there any other additional questions that have popped up in the conference room?
This is Cassie Littler. Thank you, Dr. Kennard, for kind of consolidating some of the feedback that was received. I appreciate that. I think there's one other bucket of feedback that I wonder if you could address. And that's just like if you considered any step-down process for gradual rollout for these caps and reduction of services, and if you could speak to that.
Yeah, this is Bonnie Silva. Thank you again. So for the changes that are before you today, we have not considered a step-down process, in part because we need savings this fiscal year to balance our budget. I will say for the other changes that we previewed last week, those are, we are looking at step down processes as a potential way to move those forward. I think what's important to note for the community connector and for the soft caps is that we have the exceptions process in place for the community connector piece. I do think this is just going to be hard. And as a community, we have to look forward to say, okay, how can we bring this service back in alignment to where we need it to be? And for the soft cap, again, we have the exceptions process in place and we don't anticipate, based off our projected savings, massive reductions there either. So we're hopeful that as we're working with people implementing these changes, that we can wrap around them. If it's not these services, what else might it be? Or can we, move forward with a revised plan?
Thank you. This is Cassie Littler again. I don't know if this is for you, Bonnie, or for maybe Rachel. Can you comment on where these two rules, or this one rule, is in terms of it's been voted on by the JBC and has already been through that process? Is that correct?
Anyway, this is Bonnie Silva. So yes, these two actions were in the governor's budget and the Joint Budget Committee has voted to move them forward. So they are moving forward. So we are seeking your approval to continue our state level authority to implement them ongoing. Is there anything you want to add?
This is Rachel Entrekin. I don't have anything to add, and I figured it would be great for you to answer since you were last with the JBC.
Okay, thanks.
All righty. Anybody else have any other questions, board? All righty, hearing none, Mr. Sykes, I'm just gonna hand this all over to you and let you help me get our testimony going here. Looks like there's some notes on the file too, so I'm gonna hand over to you to get folks testifying.
This is Chris Sykes. We do have some individuals that have traveled down to the room with us, so we're gonna call on them first.
I would love that. Thank you very much for taking the wheel on this.
First up, we have Patricia Mead.
Good morning, Patricia. The floor is yours for 2 minutes.
And I apologize. Patricia, you can come up and sit at the table. There's a microphone in front of you.
Thanks so much. Madam Chair, members of the room, I'm going to step back because I have a cold and I don't want to get anyone sick.
I appreciate you, Mr. McLaughlin. Please be well. All right, when you are ready, we'll start 2 minutes for you. Go ahead.
Sounds good. My 19-month-old daughter Miller was born with an ultra-rare genetic mutation that has caused a neurodevelopmental disorder that there are only 11 recorded cases of globally. There is no diagnosis code besides genetic mutation, which is extremely vague. There is little to no information on her disease or life expectancy. There is no roadmap or calculator for her clinical management. Quantifying our daily lives is a challenging moving target. As a result of her disease, Miller has developmental epileptic encephalopathy, a severe form of drug-resistant pediatric epilepsy. Those who would like to put our complex disabled children in quantifiable boxes, 20% of children with DEEs experience SUDEP, or sudden unexpected death of epilepsy, and 50% of children with early infantile DEE die before age 2. These are the numbers that should occupy my mind on a daily basis, not caps or age-appropriate calculators. Her epilepsy doesn't care she's under the age of 6. Her epilepsy doesn't care about what is age-appropriate. Every task I perform to keep her alive every day is skilled. It is a health management activity because she has over 100 seizures per day that require constant physical management and medical intervention. Each night, she wakes from seizure clusters that last over an hour. I have to monitor her vital signs after administering rescue medications that don't work. Every aspect of her 24/7 care is medically appropriate, not age appropriate. There's hardly anything about her daily life that is age appropriate. She has no skills. She cannot hold her head up, grasp items, roll over, sit up, stand, walk, eat orally, or talk. As her parent and primary caregiver, I am constantly reminded that her life is not typical or age appropriate. The trauma of having to fight to quantify our daily tasks using a calculator based on typically developing children is cruel. We are beyond aware of extraordinary care. We are the definition of it. We shouldn't have to be an exception or rely on a safety net. We shouldn't have to go through stressful appeals explaining the medical complexities of a disease that no one can explain. I urge you to consider children like Miller and parents like me when considering placing caps on health maintenance activities.
Thank you so much for your testimony. We are grateful that you came to talk to us today. Thank you so very much. Do we have a response from the department, please?
This is Bonnie Silva. Thank you, Ms. Mead, for sharing your family story. It is our goal to make sure that we continue to authorize the care that your daughter needs, and that by putting these parameters in place, we ensure that that care is available for a very long time.
Do I have any questions from the board? Hearing none. Again, thank you so much for traveling down to speak with us today. It means so much to us. Mr. Sykes, who else do we have in the room with us today?
This is Chris Sykes. We have Victoria Moole.
Good morning, Victoria. Go ahead and have a seat. And once you start talking, we'll start a timer for 2 minutes.
My name is Victoria Mao. I come here from Impacted Caregivers of Colorado. We're a Facebook group of almost 2,000 families. We do advocacy on the ground. We're not organizations. We're not political. We have absolutely no skin in the game whatsoever, except for supporting families. And that's all we care about. And that's all we do. I'm representing families like hers today. I am very well known by HCPF. I've been in every single meeting that they have for the last 4 years because I've done nothing but call on them for history repeating itself, where they constantly put out memos, changes very quickly, pull them back very quickly, make changes all the time that stress out our case managers and our families. It is a constant moving target. Nothing stays the same. Nothing remains stable. It's all changing all the time. I'm extremely upset to find out that we're now blaming case managers because I was a social worker for 15 years. And I can tell you from experience, when you have people that constantly change policies and procedures on you all the time, you are the one that is held accountable to the families. And these case managers are being daily threatened, physically threatened because of these changes. Okay. So I don't understand why we're throwing this stuff out. We're making changes. We tried to make changes to the 56-hour cap already that we had to put on pause because JBC did not vote on it. Now we've got case management that's extremely confused because they were told to do this. Now they're being told to do that. And we as advocates are scrambling. And I guarantee you I spend more hours a day trying to take care of these families than you do, because I barely sleep while I take care of my special needs triplets. So I'm trying to hold families together. I'm trying to help them understand what's happening. I'm going to every single meeting there is to try to fight this. I understand the cuts. What I don't understand is why the changes are so quick and so vast that not the case management or the families can get a grasp on what's going on long enough to even keep them from losing. That's all I have to say.
Victoria, thank you so much. We appreciate your time today so very much. Did I have a response from the department?
Thank you. This is Bonnie Silva. Thank you for sharing your feedback. I think that if you heard me throw case managers under the bus, please know that that was my intention. I think they have an impossible job, and we are doing our best to make sure that they can do that with as much ease as possible. It has been an incredibly fast-paced and challenging time. I don't think any of us want to live in a state where we're in the fiscal crisis that we're in that necessitate policies being moved forward so quickly. And so just know that it is the intention of myself and many members of my team to do that with as much stability and stable time as possible. So thank you.
Thank you, Bonnie. Do I have any questions from the board? Hearing none. Mr. Sykes, who do we have up next?
This is Chris Sykes. We have Leah Brahms.
Good morning, Leah. Grab a seat by that microphone, and once you start talking, we will start a timer for you. Thank you for joining us today.
Thank you. My name is Leah Brahms. I'm the mother of an 8-year-old boy named Atlas. He has a rare genetic condition called Lowe syndrome that affects his eyes, brain, and kidneys. It causes global developmental delays and a myriad of medical complexities. These proposals from HCPF will harm my family, but they will devastate single parents and those providing round-the-clock care. Children under 21 are legally entitled to services based on individualized medical necessity, not by age and not by a formula. Yet this rule moves in the opposite direction. Case managers are not qualified or credentialed to determine medical service hours, but this proposal effectively places them in that role. There are specific sections throughout this rule that creates a discretionary process allowing additional service units above established limits, but only through a department prescribed process requiring department approval, which raises serious concerns. First, it establishes service limitations as the baseline and shifts the burden to families to seek exemptions. This turns individualized medical need into an exception rather than a standard. Medicaid requires services to be based on individual assessment, not preset limits with discretionary relief. Second, the exception process contains no objective approval criteria, timelines, transparency requirements, or clear appeal rights. This creates real risk of arbitrary or inconsistent applications statewide. I currently work at a CMA, and there is not a clear exception process for these new proposals. Third, parts of this rule reference pending CMS approval and related waiver amendments. Approving service limitations before final federal approval creates legal and operational risk. Your role as a board is to ensure rules are legally sound and compliant with federal Medicaid law. This exception or appeal framework raises serious questions and concerns about medical necessity determinations and potential EPSDT, ADA, and Olmstead implications if individuals cannot safely remain in the community. For these reasons, I respectfully urge you to vote down this rule, at least until there is clear federal approval and assurance that individualized access to service is protected. Thank you for your time.
Thank you so much for your testimony today. Do we have a response from the department?
Thank you. This is Bonnie Silva. Thank you for your testimony. I really appreciate it. I think it's important to note that when we are looking at implementing changes that require both state and federal approval, we often do that concurrently, and they're not fully implemented until we have both. I think as we're working through the regulatory changes around how we're outlining and operationalizing these changes, the exceptions process will absolutely become more clear to the case managers. We've had to do, one step forward, what's enough information before we're fully implemented and have approval. And so a lot of this is the next step in the process is to secure the state approval, the federal approval, and then move forward with operationalizing. From a HCBS community first choice perspective, case managers are definitely allowed to authorize these services. They're considered habilitated even when they're medical in nature, and we provide some additional support around how and when that happens, and that they absolutely should be authorized based off of assessed need. The difference here is that we can have some additional parameters in place around limitations, around how many services we are willing to authorize. So the soft caps as a for example. So again, our goal here, I think the takeaway is to make sure that people have access to the services they need, especially when looking at the soft caps where those are essential for daily living. And to do this in a way that has a little bit more proactive predictability in how these services are being authorized and long-term sustainability for people such as your 8-year-old son, Atlas. He's going to need a system, it sounds like, for many years to come.
Thank you, Bonnie. Do we have any questions or comments from the board?
This is Amanda Dushinsky. I have a comment.
Go ahead, please.
I would just like to reflect on the fact that, you know, the families that have testified so far today and the testimony we received, again, reflects people who I believe, based on their testimony, absolutely will need more services than the caps apply for. And I really am grateful to hear that there will be a process for them to apply for it. And I also recognize how frustrating that is as a person who's using available services correctly and justified, that you have to jump through additional hoops, but because other people weren't using the system correctly. And I will just say, I don't have a solution for that. That unfortunately, there are people who game the system. There are people who take money that was allotted for people who should have received it and use it in ways that wasn't appropriate. And unfortunately, that's something that I think HCPF is having to grapple with. That's no one's fault necessarily in this room or of any of the people who provided testimony, but it is a reality of something that we see happen. And again, I'm not pointing fingers, but I will say that I've seen it happen. Like I've seen it happen. And it makes it very frustrating and very hard for the people who are doing everything correctly on behalf of their family, on behalf of their children, and are just trying to do the best for their community. So those are my thoughts so far on what we've heard.
I appreciate that. Thank you. Do we have any other comments or questions from the board?
Madam Chair, James McLaughlin.
Please, James.
Yeah, I want to absolutely reiterate what was said by my distinguished colleague there, and go one step further and say, based on the comments that we heard, it sounds like there's bad actors across the spectrum potentially, you know, from all different levels, and then even from outside forces. And it sounds like what I'm hearing from HCPF is a commitment and a dedication to work on that across the spectrum, to help weed that out, so that families like this that are testifying today and the people they represent continue to have access to the services that they need.
Bonnie, did you want to respond to that?
Thank you, Madam Chair. This is Bonnie Silva. Absolutely. It is really challenging when we have to look at how we administer a system that serves over 93,000 Coloradans with disabilities, right? We have to look at the whole and say, how do we maintain this extraordinary infrastructure that we've created, the service package that we've developed, the support systems, and do that in a way where we can have confidence that it will be here for many years to come. And there's outside forces and there's many things that we're contending with all at once. And so we are doing our best to develop a comprehensive strategy that is protecting what we have in a way that we can have confidence that it will be there. And so the goal here is not to make sure people don't have access to what they need. Goal here is to maintain that to the extent that we can.
Any other questions from the board? Hearing none, thank you so much for your testimony today. Mr. Sykes, who do we have next for testimony?
This is Chris Sykes. We have Maureen Welch.
Hello, Maureen. Once you get talking, we'll put 2 minutes on the clock for you.
Hello, can you hear me okay?
Indeed, I can.
Wonderful. It's hard getting called on the spot with no warning. At least I get warnings other places. But my name is Maureen Welch, and I'm calling in today about Rule Packet A. I understand. First of all, I want to thank all the MSB members for their service. I know this is a thankless volunteer job, and I really appreciate your astute observations. I'm going to go a little bit high level because I know some other people are speaking today about details. I just want to remind the MSB members that we in the community look to you as our checks and balances to make sure that rules that are being changed are not harmful to our Medicaid members. I am concerned that a lot of the rule changes.
Maureen, I'm sorry to interrupt you, but do you have something in particular to discuss on this particular rule?
Yes.
Because otherwise we would
Yes.
love to go over that during public testimony instead.
Okay, yeah. I just want to say that this bill or this rule packet has a lot in it. It's a kitchen sink rule packet. The impacts on youth with the community connector, the impacts with the caps on the CFC are harmful to our members. So I want to remind the MSB members that you are not there to balance the budget. You're there to look out for us members, and we appreciate you doing that. Please make sure that when you consider this, that you do not look to your role as being anything more than looking at the impact on our members with the rule change. So I appreciate your circumspect, your expertise, and also realizing that us families out here, we know that we're going to have cuts, but we don't think they should all fall on one part of the small population. So this rule packet does impact youth under the age of 6 in a very inequitable way. They're going to lose services from Community Connector. They're also going to lose CFC because of the age-appropriate tasks, which I'm going to call out as pure ableism. You cannot compare a youth under 6 with a typical age or a typical parental responsibility. My son used to crawl on the roof. Okay, that's not something that's normal. So thank you for your service, and I'm open to questions.
Thank you, Maureen, as always. Bonnie, do you have a response?
Thank you, Madam Chair. Thank you, Maureen, for your comment. I do want to highlight that for the Community Connector change, we did pivot there from a hard cap to assessed need. I do think based off the definition, it'll be highly unlikely that many kids under the age of 6 will qualify, but it's certainly possible. And then I think that for the soft caps, again, there is an exceptions process in place, and the age appropriate standards are just, it's how these types of standards are implemented. They're used to be a barometer, not to say that a kid with a disability should have to fall within those task standards. So they're to guide the case managers in implementing those.
Thank you, Bonnie. Do I have any questions from the board? Hearing none. Maureen, as always, thank you so much for helping us understand what's going on out there in the real world. Who else do we have signed up for public testimony today, Mr. Sykes?
This is Chris Sykes. We had Megan Bowser, but Katie Wallet is going to read Megan's statement.
Well, hello, Miss Katie.
Hi there. Can you all hear me?
Can hear you fine and well, Miss Katie. Go ahead when you're ready. 2 minutes on the clock for you.
All right. For the record, I am Katie Wallet, but I'm going to be reading Megan Bowser's testimony. My name is Megan Bowser, Executive Director of Family Voices Colorado. We support families raising children with disabilities, and I'm also a parent of a 14-year-old son with significant disabilities. I understand the intent of this rule and have deep respect for the very challenging position the department is in. I acknowledge that as much as we would like to avoid cuts impacting the disability population, our state budget situation makes that impossible. Within this unfortunate framework, I do have a few concerns with the way the cuts are being framed and implemented. First, the exclusion of Community Connector of specialized, segregated, or disability-specific activities when they primarily involve individual disabilities is deeply concerning. Disability status should not be used as a proxy for whether an activity is meaningful, inclusive, or community-based. This language effectively tells members, if your community includes other disabled people, Medicaid won't support your participation in it. That is ableist and out of step with real life for many children with IDD. Second, the rule repeatedly ties eligibility to age-appropriate participation and to needs that cannot be met by a parent or legally responsible person. That misses the central reality for families. A parent can be present and still not be able to provide the intensity of support required. Think about a playground. Typical supervision can happen from the sidelines for most children. However, for a child with significant disability, an adult often needs to be right beside them the entire time, facilitating communication, safe play, and social interaction. That intensity difference is not ordinary parenting, and it is being flattened in both Community Connector and the age-appropriate task standards applied to personal care and homemaker. Finally, I'm concerned about the assumption that CAPS will create meaningful cost savings. As you heard, with past Community Connector CAPS, once a CAP exists, authorizations tend to cluster at the CAP amount, often increasing spending. I expect that same response with personal care, homemaker, and HMA CAPS. The intent is good, but the likely real-world result is limited savings paired with significant administrative burden which will fall hardest on the most impacted members and families. I urge HCPF to revise the disability-specific exclusion, define age-appropriate in a way that reflects developmental reality and intensity of need. Thank you.
Thank you for reading that statement, Katie. I appreciate it. Do I have a response from the department?
Thank you, Madam Chair. This is Bonnie Silva. So I will say it is absolutely not our intent to exclude people with disabilities from hanging out with other people with disabilities. So we'll absolutely willing to work with Ms. Bowser to understand why that's her perspective and ensure that our rule reflects that intent. We certainly don't want the tool to be used as a segregation tool either. So that's the needle that we're trying to thread. In terms of intensity and age appropriate, again, the task standards or guidelines, they're not absolutes. And so we understand that people, especially children and youth with disabilities, are going to show up with a variety of needs there. And yeah, CAPs are a double-edged sword. And sometimes you put them in place and then you see authorization go up to the CAP and sometimes you don't. And I think that these soft CAPs for these services paired with review and training from case managers, we are really hoping will result in a different outcome. So, and again, the cost savings attached to these are very, very conservative on purpose.
Thank you. I will ask if there's any questions from the board, but keep in mind that Ms. Wallet was reading somebody else's statement. So I'm not sure that she would be in too deep of a situation to answer any of the questions about that letter in particular. So I caution you on that first. Did anyone want to comment on the letter written by or presented by Ms. Wallet? Hearing none. All righty then. Thank you very much for reading that letter to us, Katie. Mr. Sykes, is Katie also signed up for her own testimony on this?
This is Chris Sykes. This is Chris Sykes. Kelly is telling me that he does not see Katie Wallet signed up for document A.
Okay. Is that correct, Katie?
Yeah.
Great, because I was just going to see if you had something to say too, and we already had you up to just get her done.
I appreciate it.
No problem. It was a pleasure to see you. And with that, we will go on to the next person signed up for public testimony, Mr. Sykes.
This is Chris Sykes. We have Sharon Miller.
Hello, Sharon. Good morning.
Hello, can you hear me?
I can, Sharon. Very good. You will have 2 minutes on the clock.
Is there a way to make my video work?
You have to turn on your own camera, Sharon.
There's no option in the Zoom call.
There is no option for
this. Is Chris Sykes. Yes, there is no option to share a video in the Zoom call.
You didn't want to share your face. You wanted to share a video. Yes, we cannot.
Oh, no, I was trying to share my face, but there's only an unmute, not a show video.
Okay. Yeah, if you're not seeing anything beyond that, I am certainly not an IT expert.
Okay.
Yeah, let's go ahead and give you 2 minutes and we'll do the very best we can with you, Sharon. Go ahead.
Okay. Good morning. My name is Sharon Miller. My son is on the SLS waiver and the DD waiver wait list. The new test standards for personal care, homemaker, and health maintenance activities create caps that cut preventative care, putting Medicaid members at risk. The direct care services calculator includes caps for each category as well as for each task. These caps create a horrifying reality. The calculator caps bathroom cleaning at 15 minutes a week. It caps laundry at 3 loads a week. Many people with disabilities struggle with hygiene. Many have accidents. Are Medicaid members expected to wear soiled clothing, sleep in soiled bedding? Are they supposed to use a bathroom covered in feces because a 15-minute cap has been met? My son is not an outlier. He is a person worthy of dignity and care. These caps have a domino effect. Soiled clothing leads to sores. Sores must be cleaned and treated. If a member wears soiled underwear due to a laundry cap, the sores won't heal. If a skincare cap has been met, treatment won't occur, leading to infection. Left untreated, this could lead to sepsis. Having daily preventative care leads to costly invasive care. Where is the risk analysis for these changes? Where is the data that proves this will decrease overall costs? HCBOF is using test definitions to cut care. Some members need protective oversight so they don't hurt themselves. HCBOF changed the definition so it excludes maintaining line of sight supervision without an intervention. If there's no funding for supervision, who will be there to intervene? Are providers going to magically know the moment an intervention is needed, drive to the member's home and intervene? This has not been thought out. Plus, it's capped at 7 hours a week. So to be clear, HCBOF thinks a member who is at risk of self-harm should be left alone once his cap has been met. CMAs can approve some exceptions, but they're hesitant. They're not medically qualified. They used to defer to Telegen. Some exceptions need HCBOF approval, which is a conflict of interest since they made the caps. It's unfair for members to be forced into a court battle because caps are being used to determine care instead of medical necessity. Vote no on the task standards. Determine care by medical necessity, not caps and definitions. And do not put us through ridiculous exceptions process that we don't even know what that is. Thank you for your time.
We appreciate you, Sharon. Thank you so very much. Do we have a response from the department?
Thank you, Madam Chair. This is Bonnie Silva. Again, I want to just highlight the task standards are actually published from out of Iowa, Ages and Stages, and they're designed to serve as a barometer and a guide for case managers when assessing the person with the disability in front of them. And the goal is to certainly not make sure that people end up in soiled clothing or with sores, but to rather to make sure that they have access to the care that they need. And protective oversight is included when sort of considered in each of those tasks. So it's a component of what they're looking at. Thank you for your feedback, Ms. Miller.
Do I have any questions from the board? Hearing none. Thank you for your time today, Ms. Miller. Who else do we have signed up for public testimony on document A today, Mr. Sykes?
This is Chris Sykes. We have John Walsh.
Good morning, John.
Good morning. Thank you very much for this opportunity to talk today. My two kids have a very rare genetic disorder referred generally as KIF1A. It's got a very wide spectrum of ailments that are associated with this. It is rare. It is not as rare as some of the other genetic mutations we've heard this morning, but it is one that will affect my kids very differently. My oldest, who is on a CES waiver, suffers from autism spectrum disorder, intellectual disabilities, and a significant anxiety disorder, as well as ADHD. And we use these community connector services very regularly. It has been a tremendous benefit to my oldest daughter. We have seen a great benefit in her social ability, her willingness to navigate social situations, and a blossoming of her ability and desire to make connections with peers. The reduction in rates for the services will drastically reduce the quality of services provided. I do not understand, if it is so popular, why we are driving to limit the services. And Ms. Silva, I did hear you try and clarify that you were not throwing case managers under the bus, but it really did sound like that was the case. And with that, it really feels like you are trying to punish families for actions of service providers. Thank you very much.
Thank you, John. I appreciate you. Do we have a response, Bonnie?
Thank you, Madam Chair. Thank you, John, for your testimony. Do their job well, and this rule package is essential in helping them do that, in addition to training. I think provider behavior, absolutely, as I indicated earlier, is a component of what we're trying to address. And the unsupported high rate associated with community connector service is where we saw providers come in and say there's a real fiscal opportunity here. And so we looked at what would be an appropriate reimbursement based off other similar services and have reduced the rate accordingly. And I am really heartened to hear how impactful this service has been for your children, especially your daughter. And that's why it's essential we can enact these changes to make sure that it stays around.
Thank you, Bonnie. Do we have any questions from the board?
Madam Chair, James McLaughlin.
Go ahead, sir.
Yeah, I want to apologize. I think Bonnie's taken a hit on a comment that I made. And I made that out of ignorance. I don't know everything related to healthcare. And so I have my area of expertise, and I come in and I ask questions to try and better understand processes. And I think in the process of asking questions, I may have inadvertently put words in Bonnie's mouth that I didn't hear her say. And so I just want to, I want to take responsibility for that and apologize for that. And just say that, look, it really comes from a desire. I want you guys to hear me too. It really comes from a desire to understand what the challenges are and better learn the processes, because I really value what you guys have to say. And we as a group, I don't want to speak for everybody, but I feel like as a group, we try very hard to truly get our heads wrapped around all aspects of this. So I apologize. That was not my intent. And please hear me that I will be better in the future.
Well, then, we've got our own feelings on the situation, so don't put that on your shoulders.
Thank you, Madam Chair. Thank you, guys.
For any clarification to make you feel better, James, I don't even know which comment you're talking about. So I would take that grain of salt. We are all here speaking from our own personal experiences. That's why we're here. And I do not wish to entertain us having to apologize for speaking. So I appreciate where you're coming from. I certainly didn't think you were trying to throw Bonnie under the bus in any single way whatsoever. Her face doesn't look like she thinks that either. So I would ask you to please allow yourself some grace, my friend.
Thank you, Madam Chair. Thank you.
You betcha. Do we have any other board members? Hearing none. Mr. Sykes, who else do we have signed up for public testimony today?
This is Chris Sykes. We have Terry Magrins Courtney.
Good morning, Terry.
Hi, can you hear me okay?
I can hear you. Once you start speaking, Kelly will put 2 minutes on the clock for you.
Wonderful. My concern, I do have a daughter that is medically fragile, and she has a very rare genetic disorder. She's one of 6 in the world that needs help with all of her activities of daily living. She, in terms G-tube fed and so forth. She is one of the children that we have, like others have spoken, that requires 24/7 care at all times. It needs to be repositioned every 20 to 30 minutes. And the same type of medical situation that you've heard from many parents. And as a medical board, I just ask you kindly to remember what is best for our children, what is ethically, how can we cause no harm to these children who have been given to us as gifts from above and our angels sent to us to live among us. How can we not cause the harm? What I'm hearing is from these soft caps that you're being asked to vote on now before the cap, while the 56-hour cap has been put on pause. There's no direct definition of what is the process for the soft caps and how is that going to work? How can you vote on something if we don't have guidelines on how that is going to work and how that may affect families that are taking care of these special angels? Same thing for the calculator. Yes, it's an objective measure, but is it fair to put that on children who are very medically dependent on services?
Thank you, Terry. We appreciate you. Do I have a response from the department?
Thank you, Madam Chair, and thank you, Terry, for sharing a little bit about your life with your daughter. I will say that again, the task standards and the direct care calculator, those are tools, and the comments around case management, right? They have a part in this, but we need to make sure they have the tools to be successful in that. And I hope that people hear my accountability in that, the state level accountability. And this is part of why we are pushing so hard for these changes, is so they have the resources they need to be successful. So there certainly isn't any blaming on my end for those contractors. They really are essential. In terms of, again, medical necessity, from the exceptions process, we heard feedback about wanting more. And so we did add that into the rule. We revised that at a later date. So more detail than what we typically would put in is in the rule. And we're committed to, in the next 4 months, really, as we look to operationalize that and implement these changes, to make sure that we appropriately thread the needle of the importance of transparency around the exceptions process, and also not giving people like an exact playbook to get around it, right? Like that's always hard at a state level to figure out how you're really clear around what's allowed, and because there are outliers that will game the system. Like how do we do a good job there? So we are very committed to doing it there.
I'm sorry, I'm having some trouble with some background noise. I'm not sure if that's coming from the room or from Terry, but if we could all center in on making sure that we can hear, I can still hear you talking, folks. Terry, I believe it's your background. Could you please mute? I went ahead and muted Terry. Thank you for that. Do we have any other questions from the department?
No, Madam Chair.
Excellent. Any other comments from the board on that? Hearing none. Very good. Thank you, Terry. Mr. Sykes, who else do we have signed up?
This is Chris Sykes. We have Brianna Hayes.
Good morning, Brianna.
Hi there. I hope you can hear me.
Hi, Brianna.
My name is.
We can hear you.
Okay,
You'll have 2
perfect.
minutes on the clock.
Okay. My name is Brianna Hayes, and I disagree that the changes to Community Connector and CFC will save the state money. I have a 4-year-old daughter who has a genetic disorder and multiple health concerns. Due to the cut in my income, I would have to get a job outside of the home and would need to place my child in ABA at full-time care, which will cost the state probably about 48% more than it costs currently for her funding. The cost to the state will go from just under $8,000 per month to about $11,500 per month, which is about a 48% increase. Currently, she has 10 hours of Community Connector at $48 per hour, Homemaker at $26 per hour, and 31.5 hours of CNA at $34 per hour for 24/7 care. Her Community Connector after these implementations would be cut to 0. Her Homemaker will be minimized if she even gets anything at all. And CNA hours will be cut by at least half. And instead, we will have to place her in an ABA, which the combined rate for RBTs, and BCBA for her care in the ABA Center would be $57 per hour. I urge you to object this rule in favor of young kids with disabilities.
Thank you so much, Brianna. Do we have a response from the department?
Thank you, Madam Chair. Thank you, Brianna, for sharing a little bit about your family. You know, as policymakers, we have to look at the services and the policies that we're developing and not necessarily family income. And so I know that the issue that you highlighted is one that's really central to what does this mean for me as a family. And that's something that I'm deeply empathetic to, and also not from a place in which we can craft solid policy going forward. So we have to look at what's appropriate for the service and what are those parameters. I do think we'll absolutely look at what other services people might be utilizing as we implement these changes to make sure that ongoing are we achieving the goal of being good stewards of dollars and having the right policies in place to support people. I definitely appreciate your feedback.
Thank you, Bonnie. Do we have any comments from the board? Hearing none. Thank you very much, Brianna, for your testimony today. Mr. Sykes, who else do we have signed up for public testimony today?
This is Chris Sykes. We have Mary Hennick.
Hi, Mary. Good morning.
Hi, my name is Mary Hennick, and I'm testifying on behalf of Colorado Advocates for Adults with Intellectual Disabilities. HCPUF's statement that this emergency rule makes only 2 major changes is incorrect. It makes a third significant change. The task calculators for both adults and pediatric members have been modified, and maximum minimum minutes have been reduced for multiple tasks. The rule references these task calculators, yet the actual worksheets are not attached. HCPUF implies that the Medical Services Board has approved them, but the board has not reviewed the full documents. Operational Memorandum 26-001 references age-appropriate norms, but it does not disclose or justify changes to adult task standards. You've heard about bathroom cleaning being reduced from 45 minutes to 15 minutes, laundry now capped at 3 loads per week. These reductions represent a significant decrease in member benefits. Anyone with a basic understanding of adults with IDD knows that these so-called maximums are in reality closer to minimums for completing essential daily tasks. They were made without stakeholder input, without transparent justification, and without full disclosure to the MSB. That renders the rulemaking incomplete and constitutes arbitrary agency action. The MSB should deny this emergency rule. At a minimum, the board should require full review of the revised adult and pediatric task worksheets and demand justification for each reduction before taking action. Thank you.
Thank you very much, Mary. Do I have a response from the department?
Thank you, Madam Chair, and thank you, Mary, for your feedback. I think it's important to note that what is in rule is that the case managers use these task standards when assessing somebody's needs. And again, they're typical guidelines. They're not, here's what a person should get. We have never put the details of those standards in rules, and like that is not something that's on the table in terms of how we operationalize the rule. So I think that's important. What we did do in rule related to the task standards is update those definitions based off feedback from stakeholders to make sure that we could have more clarity. So thank you for the feedback, and hopefully what I've provided helps answer some of your questions.
Any responses from the board? Hearing none. Thank you very much for your testimony. Who else do we have for testimony today, Mr. Sykes?
This is Chris Sykes. We have Jerica Thurston.
Good morning, Jerica.
Good
Sorry,
morning.
good afternoon, Jerica. I apologize. All of a sudden it's like 1:30. Good Lord.
I barely know the day of the week, but and I wasn't able to see any accommodations. I have a TBI and I'm a little anxious about the 2-minute. Could I request 2 minutes and 30 seconds to help, like, because I have a TBI and it's hard to communicate?
I am thoroughly thrilled to give you 2 minutes, 30 seconds. Will you please make that so, Kelly?
Thank you.
You're welcome. Go ahead whenever you're ready.
Okay. I just want to start with thanking Barry and Bill for the first time I feel like feeling heard and seen through public comment. I advocate for a lot of families, and some of the things that you guys mentioned just makes me feel like someone's looking out for me and seeing me, especially with the single parent, but also for those children who include that line of sight oversight. I wanted to share that, something I was concerned with what was said, and I am forgetting her name, Bonnie. When they were advocating for single parents, and you stated that, well, we could just reduce that to 5. I feel that when you are stating in rule that 2 people can do that 5 hours each, it would feel very retaliative if that was reduced to accommodate that acknowledgement of for single parents. And I'm unfortunate that we don't have video, because I was gonna be able to show you guys my face, and this was the first time my son has hit me where it actually drew blood. And just to give you guys a real representation of with kids with on the autism, when he's not a violent child, he's very empathetic, as much as people don't realize that with autism, but he does have a brain development where that part of the brain with emotional regulation is just not developed. And my concern is with a lot of these things, it feels like it's being put on legal responsible people or caregivers with these limitations, because yes, we don't have outside providers and we are the only person. However, the very rare times I've had outside people come in, it wasn't, I've had medicine stolen, and then to have their unique needs addressed, it's exhausting to train people to know how to care for my kids. Rather than, there was one time someone made a meal and they didn't make it exactly how my son wanted it, and so he didn't end up eating, and I wasn't aware of that till later when I was cleaning up his food. And so the reality of all of this emphasis on, outside providers can provide those care. I have 3 PASs or 4 in this town, and I have no support, no staff for those needs. But I just want them to be mindful of, I feel like, cutting caregivers or those legal responsible people, because especially after my son hit me, I know that I help other families. And when, I don't know if you guys know this, but in Colorado, a 10-year-old can get arrested regardless of an IDD diagnosis. And so to have outside providers come in scare me now after what just happened with my son, and I was able to help him regulate after. But when we're putting the emphasis on outside providers.
I'm sorry, Jenica. I'm not sure what's going on with our timer. I didn't hear anything go off, but we're definitely at time.
No, that's
there.
okay.
I
That
so
was good
appreciate
enough.
you. Yeah, no, I appreciate you so much. And thank you for taking the time to put together testimony for us today.
Yeah.
Bonnie, did you have anything you wanted to add?
Thank you, Madam Chair. Thank you, Jerica, about your experience with your son. I think it's really impactful, especially as a single parent. And I just want to say that the goal here is that there's 1 million outside providers. The goal here is to highlight that we have had providers disproportionately lean on family caregivers in a way that is not good for the people that we serve in our state. It's not good for families, and it's certainly not good for our system. And so we need to have policies that drive towards cultivating a workforce of legally responsible people, parents, family caregivers. You all are essential. And also making sure that we have a broader workforce in place. So both things are true. So I really appreciate that. And we also were able to look at nationally what our state's policies around paying family caregivers and legally responsible people, and saw that we're pretty out of line. Like most states cap it at between 40 and 60 hours, and we're at 112. And so we really need to look at how we can make sure that our payment policies are sustainable for the long term. And that doesn't mean that family caregivers aren't important. It means that they are. And we want to keep them around, and doing that is by having sustainable policies in place. And I know that's not easy, but that is sort of from a system standpoint where we're driving so that your son has access to a broad array of caregivers for many, many years to come.
Thank you, Bonnie. I appreciate that. Are there any comments from the board? All right, I'm going to interject here, team, real quick, because I'm starting to get concerned about time. We're nearly at 1:30 in the afternoon. I know that I cannot stay here all afternoon. I've already received statements from 2 board members that they need to get off the call in the next several minutes. We still have 20 people signed up to testify. Yeah. So we need to start having some conversations about what our day is going to look like here, team. I turn into a pumpkin at 2 o'clock. That's it. I'm done. And we've got 2 other people already ready to get going here, which means that awfully quickly here, we're going to run out of quorum. So,
May, this is Rachel Entrikin.
Yes.
We have 3 more people signed up for this rule.
Oh, great. I got a note that said close to 20. So I'm glad that that is incorrect.
Yeah, so we do have additional folks signed up for the public comment period.
Okay.
I know that Chris and
For
I
the
will-
clarification.
Yeah, I know that Chris and I will be staying here throughout that process.
Right. So we have 1 more person signed up for this rule.
3 more people.
3 more. All right. I'm going to do my best to stay on through the 3 more and get a vote going on this. Oh, and I see people saying that, yeah. Yeah, so yeah, let's get through these 3 as quickly as we can so that we can try to get a vote going. Thank you, Dr. Kennard. I see you wrangling your arm there. Carry on. Who is next?
This is Chris Sykes. We have Ida Baranowski. Sorry, didn't mean to butcher the name.
Hello?
Hello.
Hi. Would you say your name for us so that we can show you proper respect?
Yes, it's Ida Barnoff.
Thank you, Ida, so much. 2 minutes on the board for you. Go on ahead.
Okay. Thank you, Chair and members of the committee. Thank you for the opportunity to testify today. My name is Ida Bornowski. I live in Douglas County, and I'm speaking on the rule packet of MSB 251106B because the changes really affect my daughter. She's under 6, and this significantly reduces hours for families like mine. Lily's 4 with quadriplegic cerebral palsy, epilepsy, CVI, and a myriad of other things, G-tube, fed, all the things. But she is so bright and so smart, and she's so happy, and she's just the light of everyone. Everyone always comments on how happy she is, and she's just so smart, but she can't express herself. But a typical 4-year-old would be walking and playing on their own, feeding themselves independently, communicating their needs. My daughter can't do any of that. She can't even play on her own. I have to be there, handing her toys, opening her hands just to get her hand on a toy just to play. So I just feel like the calculator doesn't reflect children like mine. Sorry, what was that? She just really needs all the time. She needs care. She has seizures that need care. And I understand that there's supposed to be an exception process for children like Lily, but it's also, we already deal with so much stress and so much paperwork. And now we have to deal with the uncertainty. Will my case manager give me these proper exceptions to, take an account for everything that Lily needs? So I just wanted to say thank you for hearing my testimony today, and I appreciate it.
Thank you, Ida. I appreciate it. Do I have a response from the department?
Thank you, Madam Chair. Thank you, Ida. I am going to keep it short given our time constraints and just say thank you for your feedback. We'll make sure that it's incorporated as we're moving forward. We definitely want to support you and your family.
Thank you. I appreciate it.
Thank you, Bonnie Silva. Do we have any comments from the board? Hearing none. Keep them rolling, Mr. Sykes. Who do we got?
This is Chris Sykes. We have a comment from Celia Pham that is going to be read by Victoria in the room.
Hi, Victoria.
Hello.
Once you get started, they'll put 2 minutes on the clock for you.
Okay, my name is Victoria Mel, and I am reading for Cecilia Pham. Thank you for the opportunity to testify today, and thank you for serving on MSB. My name is Cecilia Pham, and I live in Denver. I'm writing today on the rule packet, emergency rule packet, because I already experienced firsthand the problems that come with the training HCPF has given this year on the implementation of these proposed soft caps. Last week, I met with my son's case manager to discuss his upcoming renewal. My son is medically complex, nonverbal, epilepsy, global delays, G-tube fed, non-mobile, takes a baseline of almost 30 doses of meds per day via G-tube, 24/7 care and monitoring. Towards the beginning of that meeting, as case manager informed me, there are now going to be caps on personal care, homemaker, and HMA, and she could not include any hours beyond those caps, period. I, having done days worth of research beforehand, was thankfully aware of the memos and proposed rules by HCPF and was able to change the route of the discussion. My son's case is still pending due to the amount of extraordinary care needed beyond the baseline care calculator. I'm extremely concerned for my son and also for other families who do not have the time to research all this beforehand to determine for themselves the care hours required for their child to prevent unnecessary hospitalization. There's currently no oversight and appeals process by someone with actual medical expertise for calculating my son's medically necessary service hours. We have letters from a variety of his providers indicating the need and time for this care. Yet the case manager supervisor is supposedly the person who will be able to decide what hours my son does or does not need. The arbitrary care calculator and soft caps have no base in reality of the life of a very medically complex child. When we give the very real hours spent caring and cleaning for my son, of all which is beyond the needs of a typical child his age, and which are proven.
Thank you for your time. I appreciate you reading that letter for us today. Did you want to respond to that, Bonnie?
Thank you, Madam Chair. This is Bonnie Silva. Appreciate the feedback on sort of experience with case management agencies, and we're happy to take that and follow up and make sure that that is being implemented as intended.
Thank you, Bonnie. Do we have any questions from the board? Hearing none. Mr. Sykes, one more, right?
This is Chris Sykes. I apologize. In that extensive sign-up list, I missed Ginny Arrington.
Oh, well, let's get Ginny on here.
Hello, can you hear me?
I can, Ginny. Once you start talking, there will be 2 minutes on the clock.
Thank you. My name is Ginny Arrington. I am a caregiver in Mesa County to my daughter. My daughter has congenital heart disease, is trach vent dependent, and has a urostomy, one working kidney, a genetic condition. After listening today, I wanted to express my concern for the age calculator. It is not being utilized as intended. We get majority of our hours through HMA, and I was told there was no way that we would get that many hours, but we have those many hours because of her trach vent. I appreciate that you are saying that there are exceptions. However, I truly believe that there needs to be more discussion with case management and a much more clear rules with what is trying to be implemented. Thank you so much for your time.
Thank you, Ginny. Appreciate you. Do I have a response from the department?
Thank you, Madam Chair. This is Bonnie Silva. Thank you, Jenny, for sharing a little bit about your family, and we'll absolutely follow up with our case management partners.
Any comments from the board? Mr. Sykes, is that everybody for public testimony on Doc A?
This is Chris Sykes. We have Julie Riskin with us in the room.
Hi, Julie.
I don't know where the camera's. Hi.
That's okay. Nobody knows where anybody is anymore. Start talking. You got 2 minutes on the clock.
Thank you, Madam Chair and members of the board. I'm Julie Riskin with the Colorado Cross Disability Coalition. I do feel your pain. I was on this board for 14 years covering 2 recessions, so I've been in your seats and I know it's really hard. We are the largest disability-led organization in the state and represent all disabilities through the lifespan, including our staff. We are all being hit with these Medicaid cuts, and not just this, they're all over the place. So this is very painful. Our experience is that massive spikes are provider, not client driven. And again, after doing this for decades, that's our experience. I am happy to answer questions about what's going on around the country because I think that's instructive. We are only supporting this because of the budget crisis, because we don't want to see things like Community Connector cut out completely or losing dental completely or any of the other optional benefits. And those are the things that are happening in other states. We believe all processes need to be codified in rules, not memos, and trainings, although trainings need to happen. We saw what happened with nurse assessor and pediatric behavioral therapy from there not being rules. And that's why we need you to pass these rules, is because we need to not have the chaos. Things need to be in rule. We have asked, and our understanding is that we have been promised, but I'm going to just say it on the mic, that our support is conditional upon review of the calculator, because we believe there's some issues there. That there must be, the exception process has to be clear, everyone understands, everyone knows what's going on, it has to be usable, functional, etc. And again, our concern is about the process, that we have a good process. And then we also, the final thing is assurance that if HCPF or the CMA or there's some delay in an exception, that services do not stop. Those are kind of what we have said we need to support this. So we are here to support this now. And if that doesn't happen, I will be back in the final and ask you to not support it. I'm happy to answer questions. And again, I know this is a really difficult situation. We want to make sure that the people with very significant.
Thank you so much for sharing your time with us. I am always interested to hear what you have to say. Thank you so much. Do I have a response from the department?
Thank you, Madam Chair, and thank you, Ms. Riskin, for your testimony. I just maybe want to say on mic that we're definitely committed to working at the review of the calculator, the exceptions process, and making sure that if there's a delay in that exception process, that the member isn't the person suffering.
Thanks, Bonnie. Any comments from the board?
Madam Chair, James McLaughlin.
Please go ahead, James.
I just want to say thank you so much for taking the time to help us understand the framework around this. I'm a huge fan. Our paths have crossed in good ways before, and I really value your opinion so much. And yeah, just thank you. Thank you for taking the time to be here today.
All right. Board, I will entertain a motion on document A.
Madam Chair, this is James McLaughlin. I can take that.
As you will, sir.
Before I do, I just want to, if I may, just make one comment, Madam Chair.
Please.
I want everybody in the room and everybody online to know that you've been hurt today. I don't see this as a great option. It is the only option that I see. I see us as doing this. I see me as doing this today to save the program and to make sure that it's able to continue moving forward. I don't do this with a light heart. And I thank each and every person here for taking the time, and every person online for taking the time to give testimony today. You guys were heard. And I hope you continue to show up and continue to give your opinion and to help guide the work that we do, because it's so important to us. So with that said, Madam Chair, I move that all emergency rules that are adopted include a finding that their immediate adoption is imperatively necessary to comply with the state or federal law or federal regulation, or for the preservation of public health, safety, or welfare, and that the compliance with CRS statute 24-4-103 would be contrary to the public interest. I move the emergency adoption of document A-MSB 25-11-06-B, revision to the Medical Assistance Act rule concerning home and community-based services, benefits, and services requirements, and community first choice section 8.7500, 8.7600, incorporating the statement of basis and purposes and the specific statutory authority contained in the records.
Thank you, Mr. McLaughlin. May I have a second, please?
This is Christina. I second.
Thank you, Christina. All in favor, please say aye.
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 All opposed? Nay. Abstentions? Can you get a count for me? I think I was the only nay. Is that correct?
Madam President, if you were a nay, the vote is 6 yay and 1 nay.
Okay, well then I guess that one passes. All right, community, it is 1:40. I have to be off at 2 because I have a life outside of this job that I do for free. So I'm going to leave it up to the board. Would you guys like a quick break before we go into public testimony? I'm going to do closing motion, obviously, first, and we're going to discuss consent agenda. Do you guys want a quick break first, or do we just want to keep pushing?
Madam President, the agenda before you do the closing motion?
Absolutely. I am just wanting to see, do we want to break first or no? Excellent, then we are not going to.
Either way, I'm sorry, Dr. Canardier, I have to go. I'm half
I do
hour
too.
past course. So bye-bye.
Very good. All righty, thank you. All right, let's discuss consent agenda real quick. I noticed that there were some contention on documents 9 and 10. So as a leader of the board, I would think we should probably hold those off consent agenda. I did speak with Mr. Pump prior to him leaving the meeting. He sent me a note saying he didn't think anything needed to go on consent agenda. So could I please get some feedback from the board?
Madam Chair, this is James McLaughlin. I would be fine with 7, 8, and 11 going on the consent agenda. If anybody else-
That was my feel in the room too, based on the yays and nays. Does anybody have opposition to that? Hearing no opposition, Mr. Sykes, please move documents 7, 8, and 11 onto consent agenda for next month, please.
This is Chris Sykes, absolutely.
And with that, ladies and gentlemen, I am going to read the closing motion. Let me get that in front of me here. I move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference. May I have a second?
James McLaughlin, Madam Chair, I'll make it second.
I appreciate you, sir. That puts that portion of the meeting into adjournment. All right, we are now going on to open forum. I can only stay on the line for maybe another 10 minutes or so. What I would like to do with the permission of the board. Oh gosh, my vice has already left the meeting. Okay. I need some guidance.
James McLaughlin to handle the rest of the meeting when you have to drop off.
Very good. I'm actually going to do that as an official passing of the torch now so that there doesn't have to be a whole thing when I hang up. That sounds good. So, ladies and gentlemen, I give you James McLaughlin, your standing chair for the remainder of this meeting. I will be stepping back into capacity of just board member. Mr. McLaughlin, hit it.
Madam Chair, thank you very much. Those are very big shoes to fill even for a few minutes. So I appreciate you. And so we are moving into the open forum, if I'm not mistaken. And do we have anyone signed up for open forum testimony?
This is Chris Sykes. We do. We have Will Martin with us in the room.
Mr. Martin. 2 minutes, starting when you begin speaking. Thank you very much for being here today.
Great. Hi, everyone. Thanks for having me. My name's Will Martin. I'm here on behalf of the Colorado Association for Behavior Analysis, or COABA, and I was hoping to provide an update on PBT technician certification. So first, I wanted to thank both the department and the board for tabling the rule at the December meeting. That's given our community time to seek some answers to important questions, particularly around provisional practice periods, sometimes referred to as a grace period, that our community's been advocating for. In recent conversations with the Colorado Attorney General's office, we received some both documents and information that I thought was pertinent to share with this board. So I included those in the written testimony that I submitted and would be happy to discuss those further. Also, since that meeting, our community has been hard at work obtaining certification for technicians across our state, and we're confident that with a reasonable supervised practice period that we can stay in compliance with that requirement, while also maintaining access to care from the children with disabilities that we serve across Colorado. PBT providers are also engaging with the legislature around some other consumer protection standards, including professional licensure for master's level clinicians. This will be the third time that we've advocated for state licensure. The first 2 times, DORA declined to adopt those recommendations, but we're hopeful this time that we'll get a different outcome. We're hopeful that we'll continue to have some partnership with both HCPF and the Medical Services Board, particularly on this technician certification rule, and look forward to seeing y'all again in a future meeting. Happy to answer any questions or yield my time, given it's been a long day. Thank you for listening.
Thank you, sir. If you'll hold. Is there any comment from the department?
Mr. McLaughlin, this is Rachel Entrican. I do just really want to thank you for coming today and providing that information. That's great. We're looking forward to working in partnership with the community, the provider community for pediatric behavioral therapy, and certainly looking forward to having a more fulsome discussion as soon as we have clarity from our federal partners and auditors.
Any comments from board members? All right. Thank you very much for your time. I appreciate it.
Thank you very much.
And Mr. Sykes, do we have anyone else signed up for testimony today?
This is Chris Sykes. We have Ginny Arrington.
Mrs. Arrington, you have 2 minutes. Let's start when you begin speaking. Thank you very much for being here today.
Hi, can I actually yield my time, please?
Absolutely.
Thank you.
I appreciate you. And would you like to, do you have someone in particular you would like to yield it to, or just to the remainder of the group?
I am currently trying to do treatments for my daughter. So I am happy to come back when I am done, or however it will work best.
Excellent. We'll put you at the end of the list, and we'll come back to you.
Thank you.
If you're able to speak at that time. We absolutely understand and respect your position. So
Thank you.
Mr. Sykes, who do we have next?
This is Chris Sykes. We have Jerica Thurston.
Ms. Thurston, you have 2 minutes, beginning when you start talking. Thank you so much for being here today.
Thank you. This is my first time with open forum. Could someone explain, like, can I speak on anything or regarding the entire meeting?
Absolutely. This is open forum, so you can speak.
Okay. Freely. Yeah, I just want to, again, I want to appreciate the board members that really felt like read my public testimony with single parents. And I just want to encourage last voice here is that if it's being passed for 2 legally responsible adults to do 5 hours each, I would just think that it would be more appropriate to change the rule to include 10 hours for legally responsible person per member versus having to separate those 2. And again, just the concern of outside providers coming in with children with behavior needs, because again, they are at risk of being arrested because they're not the parent. And I just am very protective of my home. And that's all. Thank you.
All right. Thank you very much for your testimony. Chris, did you have an announcement for the group?
This is Chris Sykes. Just to clarify, open forum is for topics that are not on the agenda. That's
My apologies.
totally understand. That's okay. We actually have an announcement for open forum that the board president has, but yeah, we didn't realize James was going to step in, so he doesn't have the verbiage.
That's okay. My voice was still heard a second time, so I appreciate it.
And ma'am, that was my error, and I apologize and thank you for being patient with us all.
No worries. Y'all have a great afternoon and good weekend.
Thanks. Chris Sykes, who do we have next?
This is Chris Sykes. We have Sharon Miller.
Ms. Miller, you have 2 minutes that starts when you begin to speak. Thank you for being here today.
Nope. Sharon Miller dropped off the call. It is Ida still with us? Yeah. Ida, sorry. Thank you very much for the correction. Ida,
are you with us today?
I am, but I already spoke. I don't need to do another speech.
All right. Well, I appreciate you being here. Thank you very much. And who do we have?
This is Chris Sykes. Sorry. Been a long day. Kelly Lyons.
Ms. Lyons, are you here? Kelly, are you with us? All right.
This is Chris Sykes. I apologize, Jerica, but we are back at you as our last individual if you are ready. Came faster than we anticipated.
Yeah, that was the problem because I wasn't sure if I signed up or not because of my TBI. So I think I probably signed up a handful of times.
So you've already given your testimony then?
Yes, you guys are off the hook with me.
Excellent. Well, we really appreciate your testimony and your input and for being here today. So thank you so much.
Thank you, everyone, so much.
I think we are. Is there anybody else?
This is Chris Sykes. There is nobody else signed up for public testimony.
All right. Excellent.
Oh, I apologize. Maureen is also signed up. I'm sorry. This is a very long list.
That's all right. Maureen, are you with us?
Get us excited.
Hello, this is Maureen again.
Hi, Maureen. Do you have anything to share in general open forum not related to one of the rules that we discussed today?
I do. Thank you.
Excellent.
Could I ask a point of clarification before my 2 minutes starts?
Absolutely.
I'm just curious. It's really hard for us out here in Zoom land to know who is still there. I'm curious who from the MSB is voting members and who from HCPF are left in the room or in this meeting, I should say.
Yeah. So for voting members, you have myself and Dr.
Amanda Glishinsky.
Dr. Amanda Glishinsky. And I know I got that wrong.
And in Zoom land with you, we have Dr. Christina Mulkey. We have, Laura Carroll. And I believe that is all that remain of our board members. And then in the room, we have Adela Flores Brennan. We have Jennifer Weaver. We have Bonnie Silva. We have Rachel Intricum. We have Chris Sykes. And we have our technical support, Kelly O'Brien.
Thank you so much. And then who is the chair right now? I'm sorry. It's hard for me to follow.
And the acting chair filling in is James McLaughlin, the very unexperienced James McLaughlin.
Oh, I think you're doing awesome.
Thank you, ma'am.
Okay, can my 2 minutes start now then?
Yep, absolutely.
Okay, wonderful. So thank you, MSB members. I really appreciate your service and also for all the staff from HCPF that are there. I know this is a really challenging time and I appreciate your input and participation. I just had a few process issues completely unrelated to the rule packets today. I do a lot of community organizing and education in our community, and there were a few things that I noticed today that as a recovering special ed and general ed teacher and community organizer, I wanted to point out. One is that the link on the agenda for the Zoom today was wrong, and that created a lot of what I call bumps in the experience for new participants in the community. Number two, I suggest the accommodation of posting all of your slide decks on the public facing MSB website. Like you have the Zoom link, you have the agenda, and all that posted under today's date. It would be really great to have the slide deck there. It's very difficult in the community to follow along without access to that deck or those decks, because there were decks for each different rule. Number three, I suggest the MSB consider limiting the department comments after every public testimony. It takes up a lot of time, and in my opinion, it is inappropriate. I think that the board should ask questions of the department instead of giving open comment every single comment to the board. It doesn't seem equitable or fair. And thirdly, I was wondering if we could put in an accommodation. Mr. Sykes does an awesome job running this meeting, and Kelly also, thank you. But it would be really helpful for us in the community, especially those who are caregiving, like one of our speakers in this open comment, to have access to know when they're coming up. So if we could do it like they do at the Capitol, where they call up 3 to 5 people and you know you're in a group, or maybe there's a list in the comments, because it's really hard for us to switch gears, and we want to be prepared and present effectively to you. So thank you for listening to my overall universal suggestions, and thank you for your service.
Thank you. And I just want to make sure I heard you correctly. So what you would like to see is, first of all, have the slide decks posted for the presentations. And I think I heard Chris Sykes say, just in response to that, I think I heard Chris Sykes say that they are going to post today's slide decks after the meeting. Is that correct?
Correct. This is Chris Sykes. Yes.
Okay.
That's awesome. That's awesome, but it'd be great to see it during the meeting while we're following along.
I will take that back to, we'll take that back to the department for further review and further consultation. Okay.
Yeah, every other meeting, they do that as an accommodation in the HCPF world. You can see the slide deck for every meeting I've gone to. So it's just something I noticed and missed. I missed having access.
Yeah, no, we definitely appreciate the input, and we'll take it back to the department for further review. And then limiting department comments, again, that's something we'll take back to the department for further review. Oh, I'm sorry, Madam Chair. You had a comment.
I do have a comment. Hi, this is Laura Carroll. I just want to +1 times 100 to Maureen Welch's request to receiving the decks ahead of time and on the page. This is something that I've been asking for our board members, as you may not know, for pretty much since I've taken the presidential role. So I'm extremely grateful to Maureen bringing this to the table, and I would like to +1 it +100. Thank you.
Excellent. Thank you, Madam Chair. Appreciate the input there. So Maureen, you have a very powerful advocate there. So we will take that recommendation back to the department for further review. So thank you very much for that. And then limiting department comments, we'll do the same. We'll take that input back. And then the next thing I heard from you was put in some accommodations so that folks know, and I know exactly what you're talking about when you testify at the Capitol, and that is very helpful. I agree. So, and we are looking for ways to streamline processes and improve practices. So I think this, your comments couldn't be more timely. So thank you for that.
Thank you, and have a good weekend.
Thanks, you as well. All right, Mr. Sykes, any other comments? I'm sorry, any other?
Chris, the only other thing I see is adjourning the meeting.
Excellent. And there's no formal process for that. So I just believe at this point, unless there's any further comments or any further questions, any comments from the board, then let's go ahead and adjourn this meeting. Meeting adjourned.
Thank you, James. I appreciate you.
Madam Chair, I always appreciate you. Thank you so much.
Talk soon, friend. Bye, everybody.